Good morning and welcome, everyone. Thank you for joining us for Ask Childhood Cancer Foundation's 2024 Educating Childhood Cancer Patients and Survivors Conference. We proudly partner with the Virginia Department of Health to be able to provide this conference free of charge. I'm Susan Lindsay, Ask Program Director. Ask was started over 49 years ago by a group of parents in the waiting room of what was then Medical College of Virginia and is today Children's Hospital of Richmond at VCU. Today, Ask is Virginia's most comprehensive provider of support services for children with cancer and their families. One of the ways Ask helps families is through direct educational support for patients and survivors. In 2022, the Virginia legislature allocated state funds specifically to support childhood cancer for the first time. These funds allow Ask to provide an education support navigator at each of the 5 primary pediatric cancer treatment centers in Virginia. Our education support navigators help bridge the gap between the medical team and the school team. They help patients and survivors stay on grade level and receive the accommodations they need to be successful. We have a really wonderful group of very experienced and knowledgeable presenters today from a wide variety of treatment centers. In addition to these presenters, you will hear from 3 Ask Education Support Navigators today as well. If you are supporting a childhood cancer patient or survivor who is treated at Carilion Children's, UVA Children's Hospital, Inova Char Cancer Institute, Children's Hospital of Richmond at VCU, or Children's Hospital of the King's Daughters, you have access to help and support of an Ask Education Support Navigator. So we will put a link in the chat so that you are able to easily find the navigator in your region. And there will be slides shown during the lunch hour with their contact information as well. Cancer treatment not only disrupts schooling, but often impacts a patient's development, which can greatly affect academic success. While the focus of this conference is childhood cancer, it is worth noting that many of the tools we will provide today can be applied to helping students with other chronic health conditions as well. Over the course of the day, you will learn about the most common types of childhood cancer, treatment, survival rates, and what survivorship looks like. You will learn about physical, cognitive, and social emotional late effects of treatment, how education plans like 504 and IEP can help, and how to use the Ask Childhood Cancer Education Toolkit. You will learn how to support the youngest learners, the importance of play for these children inside and outside of the classroom. You will hear from young adult childhood cancer survivors about their own experiences. And finally, we will conclude the day by walking through 2 case studies. Shortly, we will put up a slide with a QR code to the pre-conference survey and a link to the survey in the YouTube comments. If you have not already, please take a minute to complete the survey. Completing the pre- and post-conference survey is required to receive a CNE or CEU certificate. These surveys also allow us to measure the learning impact of the conference, which helps us ensure continued funding to provide this conference free of charge in the future. Throughout the day, you can ask questions to any of our speakers by typing in the chat feature on YouTube. At the end of each session, we will get to as many questions as possible while also promising to stay on schedule. I will return at 9:15 to introduce Dr. Borowitz, our first speaker. So grab that cup of coffee, take the pre-conference survey, and we'll be back soon. All right, welcome back, everybody. We are going to get started with our first presenter today. It's my pleasure to introduce Dr. Violet Borowitz, pediatric hematologist oncologist with Carilion Children since 2014. In addition to caring directly for pediatric oncology patients and survivors, Dr. Borowitz is the pediatric liaison for Carilion Hospice, as well as the medical director for Care Connection. She is an associate professor in the Department of Pediatrics and VTC School of Medicine, and an assistant professor in the Department of Pediatrics at Edward Via College of Osteopathic Medicine. In 2019, she became an associate program director for the VTC Pediatric Residency Program. A very big thank you to Dr. Borowitz for taking time out of her busy schedule to share her expertise with us today and provide an overview of childhood cancer. Welcome, Dr. Borowitz.
Thank you. So as mentioned, I'm going to go over just a brief overview of childhood cancer. I do have no financial disclosures. The objectives of this talk is to really go through the most common types of childhood cancer that we see, and to review how frequently childhood cancer occurs, how childhood cancer differs from adult cancers, what treatment entails for a patient, what our survival rates look like, and what survivorship looks like. So just a brief overview of childhood cancer. Childhood cancer, we say, as this general term for any child who has cancer, but it really isn't a catch-all diagnosis. We have so many different types and variations of cancer that we see, different treatments, different things that come into play when it comes to kids who have cancer. So really, childhood cancer is just does not define enough of what these kids go through. Cancer is not biased by race, gender, or socioeconomic status. 47 children are diagnosed every day in the United States. Most of the current standard treatments that we have now were approved over 30 years ago. On average, clinical trials for children begin 6.5 years after adult trials have been conducted. 90% of children and adolescents who are diagnosed are treated within one of the 200 children oncology group hospitals that exist, with about 100 active clinical trials ongoing at the COG hospitals. The Children's Oncology Group is a international cooperative group that looks at studying childhood cancer treatments and also looking at late effects in childhood cancer survivorship in terms of trying to improve what we are doing for kids with cancer. As I mentioned, there are a lot of different subtypes, and even within the different types of cancer, there is also multiple types that may be defined within that. We have acute lymphoblastic leukemia, and that can be B cell or T cell. We have acute myeloid leukemia, Hodgkin's lymphoma, non-Hodgkin's lymphoma, neuroblastoma, Wilms tumor, hepatoblastoma, which is a tumor of the liver, retinoblastoma, which is a tumor of the eye, various types of brain tumors, rhabdomyosarcoma, osteosarcoma, Ewing sarcoma, soft tissue sarcoma, and germ cell tumors. Again, even within these categories, there may be multiple different subtypes. Within AML, or acute myeloid leukemia, there are 7 different types, which has 7 different types of treatment that these patients may receive. From the types, leukemia is the most common type that we do see. 28% of children who are diagnosed with cancer have leukemia. Tumors within the central nervous system, so our brain tumors and spine tumors, those are the most common solid tumor that's seen. About 26% of patients in pediatrics have central nervous system tumors. Lymphomas are the next at 12%, and then neuroblastoma is the most common solid tumor that's diagnosed outside of the central nervous system. About 6% per year are diagnosed with neuroblastoma. So just to go over some statistics, in 2023, it was estimated that a little over 15,000 children and adolescents between the ages of 0 and 19 would be diagnosed with cancer. It's estimated that a little over 10% of those would die of the disease in the US. Among children who are 0 to 14, almost 10,000 of those were diagnosed with, again, a little over 10% who would die from it. And then adolescents considered the ages of between 15 and 19, it was estimated that a little over 5,000 would be diagnosed and 550 would die from the disease. So children versus adolescents. Children, again, defining them between 0 and 14 years. The cancer incident rate actually stabilized between 2010 and 2019, so there was no growth in the incidence of cancer during that time frame. Leukemia is the most common diagnosis in that age group. Adolescents, however, with the 15 to 19, we are still seeing a cancer incident rate that continues to rise about 1% per year. Lymphoma is more common in the older age group. So what are some things that we look at between children and adults? Big thing is we say often in pediatrics, children are not little adults. There is a huge difference in how we treat children versus adults in general in medicine. So we know that a lot of these cancers that get diagnosed, they're not strongly linked to lifestyle or environmental factors that we see in adults. Kids are not getting cancer because of smoking or tobacco exposure or alcohol or diet. Only a small number of those are caused by DNA changes that can be seen in the tumor itself. Treatments are often more successful in pediatrics. And a lot of this is due to the fact that we are a lot more aggressive with a lot of our treatments because kids are generally healthy at the time of diagnoses. So when adults get diagnosed, oftentimes they may have other conditions like high blood pressure, diabetes, high cholesterol that kind of play into how well they are going to be able to receive chemotherapy. Whereas most pediatric patients are pretty healthy when they are initially diagnosed. Again, another big difference, as I mentioned, is that the children's oncology group. So most children actually do receive treatment within pediatric cancer centers. They also, we initiate treatment a lot more rapidly. Most leukemia patients will get treatment started within 5 days of diagnosis. Usually we try to aim for as soon as possible once we know what kind of cancer they have. There can be communication barriers, unfortunately, with children, just because of their inability sometimes to communicate what their symptoms are. That can lead to a delay in diagnosis. So sometimes these kids are actually a little further along in their staging because we don't always pick it up quickly enough if they cannot tell us what symptoms they're experiencing. And there are sometimes that kids are very resilient, and sometimes those symptoms are brushed off for other reasons because they are able to play and still kind of adapt to whatever they're experiencing. There is also a greater concern for long-term side effects because kids are now living decades after their course of treatment is completed, and we are seeing a lot more late effects that are affecting our pediatric population. And there's a lot of difficulty in research because kids' research in children tend to lag behind adult research. There's also a lot more rarity with some of the subtypes. And so getting more specific research in that realm is also very difficult. So going through some treatments, typically we give chemotherapy through a central line. Some may also receive oral chemotherapy or other medications at home. And then some do require intrathecal chemotherapy, which is delivered to their spinal fluid via a lumbar puncture or spinal tap. So for any women out there who have had children and may have had epidurals, it's very similar to that process where we're doing a spinal tap to be able to deliver chemotherapy directly to their spinal fluid. And this is in cases of kids who have leukemia or certain types of lymphoma where we are trying to treat or pre-treat any disease that may go to that area, that may exist there or may go to that area. Again, treatment really varies based on their cancer type, based on their phase of treatment. Some patients require inpatient treatment, and so they are admitted to the hospital. Sometimes it's because they need to get additional hydration through their central line. Sometimes their chemotherapies are longer infusions that we cannot complete in a clinic day. Some of our chemotherapies infuse over 24 hours, sometimes over 48 hours. So due to those length of times, they do need to be admitted to the hospital. We do drug excretion monitoring for some of these chemotherapy drugs that we give. These kids for chemotherapy alone may be in the hospital anywhere between 2 or 5 or more days during their treatment. And then they also may be in the hospital extended out from the completion of therapy due to side effects that they may experience from their treatments. Outpatient treatment, the length of time can vary anywhere between just a push drug that's given over a few minutes to requiring to be there all day for various chemo's. And again, frequency of office visits can vary. So they can be there 1 to 5 days per week, every week. They may be there 1 to 5 days per week, every 3 to 4 weeks. They may be there monthly clinic visits. It really depends on where they are in their treatment and what treatment they're receiving for their diagnosis. Some patients may even need radiation therapy on top of that. So they may get radiation therapy Monday through Friday for anywhere between 6 and 30 days, depending on their type of tumor. And then additionally, some patients will need surgery for their tumor and will require an extended period of recovery postoperatively. And then depending on what type of cancer they have, again, the surgery may happen prior to the start of chemotherapy or radiation, or it may occur in the middle of treatment as well. Along with their treatment, because we are giving toxic chemotherapy to be able to fight these cancers, they often have appointments that they have to come to the office outside of their chemotherapy days. So they are getting sick visits because they have a fever or they may need a blood or platelet transfusion. All of these are side effects secondary to their treatment. We know that our chemotherapy will affect cells that are growing fast, but it doesn't differentiate between good and bad cells. So this can affect their blood counts, and their blood counts can go lower, requiring this blood transfusion and also making them more at risk for infection because they're white blood cells as well. Sometimes they may even need to be admitted to the hospital if they're severely immunocompromised. If their white count is very low and they have a fever, oftentimes we have to have them admitted outside of their chemotherapy for an extended period of time until they recover from that as well. So just to go into some information about survival rates. So in the mid-70s, only 58% of children, 65% of adolescents actually survived at least 5 years from diagnosis. That has significantly improved with all the research that has been done, especially through the Children's Oncology Group. The data from between the 2013 and 2019 5-year survival rate data, 83.2% of children who were less than a year of age survived, with a higher percentage of children, 87.8%, for kids who are ages 1 to 4. It does go a little bit lower at about 85% for those between ages 5 and 14, and about 87% for children between the ages of 15 and 19. So our data has shown that we have had significant approval in our survival rates, which also means we have a significant increase in our cancer survivors that are experiencing late effects from treatment. We have seen dramatic improvement for several of our cancers. The 5-year survival rate for ALL, so acute lymphoblastic leukemia, was 57% in 1975 and now 92.1% between that 2013 and 2019 timeframe. Those with non-Hodgkin's lymphoma in 1975, their survival was 43%, and now it's 91.4%. However, even with this, some of our cancers we have not actually advanced pretty significantly due to lack of advancements in therapies that exist for cancer. There is a specific type of brain tumor called diffuse intrinsic pontine glioma. 50% of those patients survive less than 1 year from the time of diagnosis. Only 10% of them will survive 2 years from diagnosis. 5-year survival for the ALL that I mentioned in children is a lot higher at 92%, but the data for adolescents was only 77%. And then Ewing survival rate, which is a type of bone tumor, 5-year was 78% for children and 64% for adolescents. So some of our tumors really haven't had progression in our treatments because there just hasn't been newer chemotherapies that have been available for these cancers. We do continue to try to do research. Our goal is to try to improve outcomes as well as improve the late effects and secondary malignancies that our patients are seeing. The cancer mortality rate declined by more than 50% between 1975 and 2020. In 1975, it was 5.1 per 100,000 children and adolescents, and in 2020, it was 2.1 per 100,000 children and adults. So just some quick information about survivorship. As of January 1st, 2020, there was an estimated almost 500,000 survivors of childhood and adolescent cancers that are estimated to be alive in the United States. Approximately 1 in 750 young adults. The number of survivors continue to increase, and the incidence has been rising slightly in recent decades because their survival rates are overall improving. They do still need regular medical care because of their increased risk of complications that's related to disease or treatment. So these are the late effects that I mentioned. They can develop secondary cancers. They may require joint replacements because of side effects from therapies such as avascular necrosis that can damage their joints. They can develop hearing loss. They can develop congestive heart failure. And these late effects occur at a much younger age than when we see them normally in adults that have not gone through this, experiencing this, and later in life. And so it's really important, the research that's being done into cancer survivorship, because we are seeing so much of this now that our cancer survivor rates have improved. More than 50% of our pediatric cancer survivors have experienced a severe or disabling complication, or even death by the time they reach the age of 50. Known as premature aging. 73% of them will have a chronic health condition, and 42% will likely experience a severe disabling or life-threatening condition or even death. We know even with survivorship, there's a lot of learning problems that can come hand in hand with this, which is where our education navigators have made a huge impact on our patient population with helping them succeed in school. We know that there's problems neurocognitively with processing, with handwriting, spelling, reading, vocabulary, math, concentration, attention span, their ability to complete tasks on time, memory. I've had, currently I have a 22-year-old patient who is attending community college and has recently told me that he really is struggling with his memory and ability to process and remember things. Planning, organization, problem solving, social skills. So there's a lot of things that go into the survivorship piece of this, where these young adults are needing more assistance because of the things that they've gone through. Other things to think about with cancer survivorship is future fertility. We know that future fertility can be impacted. We know that some parents and families want to try to plan for that. There have been ongoing studies for fertility preservation, both testicular and ovarian. There have been multiple things that have been done to try to preserve ovarian function. I know there are centers that are also able to provide testicular ovarian biopsy and preservation of their fertility function as much as possible. It's also important to consider that peer support is very important for survivorship. And so having a peer group of cancer survivors is something that is incredibly important for our cancer survivors, because they are all experiencing things that they don't always necessarily know who they can talk to or how they can get help. Mental health is another concern. Anxiety, depression, post-traumatic stress disorder is very big in our patient population, especially when they go through it at a young age and don't really get much of a say in what is happening to them. And then psychosocial support. So finances, education, the occupational impacts and transition to independence. Some of our patients have a hard time with being able to function full time in a job because of late effects that they're experiencing, whether it be seizures or something else that is impacting their ability to function on a daily basis. Again, the Children's Oncology Group does have ongoing research to try to decrease late effects, but we do know that the things that we are doing to get our patients into cancer survivor place is causing a greater impact for their lifelong journey. And so it is really important for all of the cancer survivor research that is still ongoing. I think that's actually all that I have. If there are any questions, I am very happy to answer anything that might come up.
As we wait for questions to come in on the chat, I have a couple of questions to get us started.
Yeah.
So at the beginning of your presentation, you mentioned a central line. Can you explain a little bit about what a central line is and how it's different from a portacath? And then, sorry, it's a long question. And then can children go back to school? Well, I know they can go back to school with a portacath. Do they ever go back to school while they still have a central line?
So yes, so the portacath and the central line are kind of the same thing. So portacath is also considered a central line. Some central lines may be external, so those are Hickmans or Broviacs where they're hanging out, but those patients can attend school even if they have a Broviac or Hickman. But I kind of put central line as a catch-all diagnosis separate from a portacath, or catch-all term separate from a portacath, just because some of our younger children are too small to actually get portacaths. Usually they will definitely not do it under 6 months. And sometimes even under a year, depending on their size, that they have to do an actual external central line. So the big thing with the central lines, because they are external and in and out, they just have to be, the families actually have to learn to flush those daily with heparin. Whereas a portacath does not need to be flushed every day. The nice thing about a portacath is that when the needle is not in and it's de-accessed, those patients can still go swimming in the ocean. They can still take baths. They can still take showers. They can go swimming in the pool. Central lines that are external, unfortunately, they cannot submerge those in water.
And then we do have a question in the chat. Where are studies being done on late-term side effects?
Where?
Yes, where?
So the Children's Oncology Group has several ongoing studies that are opened at various COG institutions across the United States, and a lot of it is survey based to try to figure out what late effects are being experienced by cancer survivors, as well as what some of our studies are doing is looking at decreasing some of the chemotherapy we're giving to also decrease some of the late effects that we're seeing. So, for example, when I first started training, the leukemia, for example, when they got into maintenance chemotherapy, they were getting every 12 weeks so that they're getting less chemotherapy over time. And all of the data showed that it was basically equivocal. And now we have changed what our standard of care is to do those pulses every 12 weeks. So that has helped us know that we can decrease some of the late effects that we're seeing by giving less steroids.
Another question. Are there less late-term side effects for cancers such as Wilms versus the more common tumors, or is it about the same?
There are less late effects with certain tumors, yes, just because they do get less chemotherapy, but there is also different late effects. I think for my kids with Wilms tumor are more likely to have something called foot drop from their vincristine, because vincristine can cause what we call a peripheral neuropathy, where they just are not able to pick up their foot while they're walking. And I see that more frequently in our Wilms tumor population because they get so much vincristine versus our other populations of patients that don't get as much vincristine. So the late effects may be less in kids who are getting less therapy, but they are also different.
Any other questions? That participant said, thank you, I'm an educator, but also have a Wilms tumor 18-month-old.
Yes, they really do in general seem to do pretty well because they do get less chemotherapy, but
I have a question. This is kind of specific to your treatment center. So Dr. Borowitz is in Roanoke, Virginia, which is in Southwest Virginia, which is a more rural area. So I know families can travel great distances to come into treatment. So can you give an example of a family who is driving a great distance and how frequently they're needing to do that to get treatment?
Yes, actually, right now we have one family who's a teenager who has Hodgkin's, and they live 2 hours from us. And his treatment is there's 5 cycles of it. And his first week, it's 3 days in a row that he has to be in the clinic, and they're long days. And then the following week, he comes back for a 1 day visit to the clinic, and then he gets a break from us. And then he has to come right back again the next week for 3 days in a row. So typically when they're driving those 2 hours, a lot of times our family will actually try to stay them on a McDonald's house to make it a little bit easier on them travel wise, just because of that distance. Some families are not actually able to do that too because of work or for whatever reason. So some of them are actually making that trek daily.
It's tough. It's hard to imagine that
Yeah.
stress on a family.
The furthest family I had coming was 3 hours away.
Okay, we have a question. I know chemo changes the child's taste. Once treatment is completed, how can we encourage better eating habits? It's a great question.
That is an excellent question. One of the things that I have been seeing in our patient population is a trend towards increasing obesity as well because of these significant changes that they go through, because we're constantly so worried about their weight gain, weight loss that they experience during therapy, that we're pushing so much food on them that all of a sudden they come off therapy and we're having trouble keeping up with them. It's really exposure. It's exposure to foods, it's exposure to textures, it's exposure. And so that's really what the big thing is. And I often tell families, like, it's just about continuing to expose these kids to things. I will also say that I had a teenager who will not eat asparagus anymore just because of the peg asparaginase that he got. He was like, the name is just too close and I cannot eat, even though they don't. It's just because of the name, because of the words. He's like, nope, won't do it.
Does their taste ever go back to, or is it changed forever?
Most of them do go back. I have had one who has said it's always changed a little bit, but everyone else has been able to go back.
A question came in: if the chemo were less aggressively paced, would the late effects be less intense?
That is a great question. I don't know, that we have not studied that, because we know that certain tumors do better with the more aggressive pace. So for example, Ewing sarcoma, it was something that used to be, I guess, technically less aggressively paced because it was given every 3 or 4 weeks. And a lot of the data showed that trying to give that every 2 week cycles actually led to better outcomes from a cancer, like being able to get them to become cancer survivors. So part of the problem is trying to get them into that cancer survivor place. We have to do our aggressive treatments.
Sure, that makes sense. Any other questions for Dr. Borowitz? These were great questions. Thank you, guys.
Yeah.
All right. I don't think we have any more questions coming in. Thank you so much for taking the time to be with us this morning and give us this really great, insightful information.
Absolutely. Thank you for having me. It was a pleasure.
So before we go to break, we have a couple videos we're going to show of some survivors who talk about their late effects. One is cognitive late effects, and the other video is social emotional late effects, which will lead us in, when we come back from break, it'll lead us into our topics about late effects. So we will, as we get those up and going, I would love to, if everybody in the chat could tell us where they are watching from, because I know I've gotten a couple emails from folks who are very far away, even in other countries. So we would love to know where you're watching from today.
Hi, I'm Justin Jennings.
I'm Liz, Jack's mom.
At the age of 13, I was diagnosed with,
Myxoid liposarcoma.
and the things I struggle with most with at school is brain fog and walk overload. Basically, too much walk. When I come back from treatments, just piles up too much.
I will say that our school system, through middle school and high school, has worked really well with us. The administrators, the staff, the faculty, um, the counselors have worked really well with us. A number of his teachers have dealt with this on a personal level, overcoming cancer themselves, and unfortunately having worked with other students in the past with this disease. So they have, unfortunately, a lot of experience. So they've worked really well with us. They're very sympathetic and empathetic, and they give Jack a lot of the resources and time that he needs. But he still needs a lot of extra support and resources, and they do work really well with us in that aspect. But it is something that he struggles with.
Hi, I'm James Molidor. I was diagnosed with acute lymphoblastic leukemia when I was 12. I am now 17, and it really had a little bit of an effect on my life socially because I'm homeschooled, so most of my schooling sort of stayed the same, but where I get most of my social interaction is from my extracurriculars. So I do theater, I do Boy Scouts, I do dance, and all of a sudden I just couldn't do all those things anymore. So I knew I had people on the outside sort of supporting me, but I couldn't see them because I was trapped in my house for a month, 2 months, until, actually it was more like 6 months. All these things I loved, the things that kept me going, my performing, I couldn't do. Eventually, about 6 months in my treatment, I did a show, but I couldn't go to rehearsals, so I had to FaceTime in for the entirety of the thing until 7 days before the show, when I actually went into rehearsals. And it was just sort of, it was a struggle, and I really missed my friends and doing all these things, and it has affected me. Like, I think I would be a lot further along as a performer, at least, and I miss those really important years of growing with friends. So a lot of times I find it harder to get close to people and make friends, just because those are such formative years, those years from like 12 to 14, where I just was isolated from everyone else. So maybe I've talked too much, but that's sort of my experience with it. I think that's important to know.
All right, so Dr. Borowitz might still be with us. We had one more question come in. She may have already logged off. Oh, she might be. Oh, she is still with us. Excellent. We had a question come in. Because of the negative effects of chemotherapy, can a holistic approach be implemented? I guess for the patient to have a healthier life, less late-term effects, I think is the question.
Yeah, absolutely. I also do pediatric palliative care for our hospital. And so I am a big proponent of trying to bring in other aspects and not just the chemo drugs. So I do think that it can be. There's still some things with complementary alternative medicine that just hasn't been studied. So we don't know impacts long-term on certain things, but I'm a big proponent of trying to do whatever we can to kind of decrease the mental and psychological stress that patients are going through. A lot of times with my families, I tell them, look, my goal is to get you through this, but also to try to keep your life as normal as possible when you're going through something like this. And it's because it is a game changer and a life changer. So trying to keep them on track with school, trying to keep them on track with their life, trying to keep them in those social activities as much as possible is important, because it does impact them long term, as we just heard from a patient about what kind of changes that they experience when they're isolated from their friends.
Any last questions before Dr. Borowitz gets back to her patients? All right. Well, thank you again, Dr. Borowitz, so much for taking the time to be with us. We are going to go to break. We will come back at 10:05, and we will start our sessions on late effects. All right, welcome back, everybody. Our next presenter is Evelyn Joran Thiel, pediatric nurse practitioner who recently retired from UVA Children's Hospital, where she served as the advanced practice provider coordinator for the pediatric survivorship program since 2012. Evelyn will share about the physical challenges childhood cancer survivors may face and the impact on their school day and studies. Welcome, Evelyn.
Thank you, Susan, for that introduction. And I'd like to thank the Ask Foundation for giving me the opportunity to participate in this conference. This morning, we're going to talk about the physical late effects in school-age survivors of childhood cancer and the impact that those late effects can have on their school performance. Let's see. Megan, I'm having difficulty advancing my slides.
Click that forward arrow.
Yeah, okay, great. Okay, I have no financial relationships to disclose. And this morning, we're going to discuss physical late effects by body system. We're going to identify accommodations for these late effects and how to optimize academic performance and the student's satisfaction with school attendance. And we're going to talk about the physical and emotional burden of these late effects on the student. So what are physical late effects? These are long-term treatment effects that are the result or side effects that developed during treatment with radiation, chemotherapy, surgery, or it can be the result of the impact of the tumor itself on surrounding tissue. And these side effects did not resolve after the end of treatment. And then there are also another type of similar side effects, but with a different onset. And these are late effects that manifest years after the completion of treatment in response to the student's growth, development, aging, or physical decline. And an example of late effects that develop later would be a leg length discrepancy after limb salvage surgery. As a child grew, the leg that was affected did not grow to keep up with the length of the healthy leg. Physical late effects can be of varying degrees. They can be clinically obvious and very visible to classmates, such as amputation. They can be clinically subtle and only visible to the trained observer, such as the student in the middle picture who has hearing aids. Or they can be subclinical or invisible to classmates. And these are usually of neurologic or endocrinologic origins. Visible late effects are usually of the musculoskeletal system and the neurosystem. These would be things such as amputation, leg length discrepancy, limited mobility, scoliosis, or osteonecrosis, or avascular necrosis, as Dr. Borowitz mentioned this morning. Neurologic visible late effects would be gait disturbance and poor balance, and this could be from the treatments of for brain tumors such as neurosurgery or radiation to the brain. Bilateral or unilateral extremity weakness could be a very visible late effect that stays with a student, and this would be from stroke that was experienced during treatment. And oftentimes these patients have chronic pain. Accommodations for musculoskeletal or neurologic late effects include anything that makes mobility easier for the student. Having a handicap parking spot if they're a car rider or if the student is driving. Having a wheelchair at school. Elevator access. Being allowed extra time between classes before the halls are crowded. Having a conveniently located locker. Having preferential seating in the classroom. If they have scoliosis, it may be painful to sit, so having a pillow or an adaptive desk would be helpful. Other equipment may be needed to make it easier for them to sit in class. Being able to participate in PE, either adaptive PE or modified. Having physical or occupational therapy. And oftentimes these students will have a prosthetic, and they're usually very poor fitting and painful. So the student may need to take breaks during the day to ice their limb or to take pain medication. So having access to the school nurse for prosthetic issues would be important. Other visible late effects that can have a significant impact on body image are permanent alopecia, and we see this with patients who were treated for brain tumors, and this hair loss is the result of surgery or radiation to the brain. Radiation to a child who is very young will have arrested growth of the skin, soft tissue, and bones in the irradiated field. The younger the child, the greater the impact. And they may, if they've had radiation to the face or the body, they may have asymmetry or disfigurement as the healthy part of their body grows and becomes larger or more developed than the irradiated part. If the child had a stem cell transplant and experienced graft versus host disease, they can have skin changes such as hypo or hyperpigmentation or scarring. And so to address these accommodations, and these are soft accommodations, but still just as important, the student should be exempt from the no hat or head covering policy. They should have access to regular counseling. And if they could have a safe space during the day where they could go just to kind of retreat and get a break from the anxiety of feeling like they're being that they stand out. It's very important for them to feel like their disability or their difference isn't all that their classmates see. Okay, so invisible late effects. These are the clinically subtle or subclinical late effects. And these usually affect the sensory system, the endocrine system, again, the neurosystem, and several systems that all culminate and contribute to fatigue. These invisible late effects that include the sensory system will be hearing loss, And this is caused by radiation or chemotherapy. Again, the younger the child, the more susceptible they are to ototoxic chemotherapy. And if they're getting radiation around the brain, in the brain, or towards the ear, in the ear region, the synergy between chemotherapy and radiation is can increase the hearing loss. This hearing loss presents soon after treatment, and it is the result of damage to sensory hair cells in the cochlea. This hearing loss is detected in the higher frequencies first, and unfortunately, this can affect the child's speech development. There are several childhood cancer diagnoses that occur in infants and toddlers. And unfortunately, these tumors, hepatoblastoma, neuroblastoma, include chemotherapies that are ototoxic. So those young children are at high risk for hearing loss. Vision loss can occur as enucleation, which is the removal of the eye. And this is the surgical treatment for a tumor called retinoblastoma, usually picked up in infancy or in toddlers. Vision loss can be because of cataracts, which are caused by total body irradiation or radiation just to the orbit to treat soft tissue tumors. There's a specific chemo drug that can cause cataracts, and the use of long-term steroids can cause cataracts. And we see long-term steroid use in our patients who have had stem cell transplants to manage graft versus host disease. Thirst is also a late effect that we see in these patients, and this can be caused by xerostomia or dry mouth, which is the result of damage to the salivary glands from radiation. Endocrine problems can cause thirst, specifically diabetes insipidus, and there are certain medications that can cause thirst. Accommodations for these sensory late effects include hearing aids, and these children are usually plugged in with audiology and are tested on a regular basis to make sure that their hearing aids are adequate. Amplifier systems in the classroom that the teacher can wear or the student can wear. Preferential seating, speech therapy may be needed. For vision issues, voice recognition software, audiobooks, or recorded lectures are helpful. The student may need to administer eye drops during the day or other medications, and they should also be allowed to carry a water bottle. Invisible late effects that affect the neurosystem can be seizure disorder, peripheral neuropathy, and neurogenic bladder. Seizure disorders can be caused by the treatment for brain tumors, neurosurgery, and cranial radiation. They can also be caused by certain drugs, specifically methotrexate or cytarabine when given in high doses, or when administered intrathecally, or which means directly into the cerebral spinal fluid. Accommodations for seizure disorders, very important to have a seizure action plan in place. And the Epilepsy Foundation has a beautiful template for a Section 504 seizure plan. The accommodations may include administering medication, nerve stimulator implanted, which is something similar to a pacemaker. Instead of sending signals to the heart, this sends signals to the brain, and it can divert the signals that are allowing the seizure to take place. This is activated with a magnet, and school personnel who work with the student at risk for seizure disorder will be taught how to use that magnet. Peripheral neuropathy is also something that is not visible to classmates, but can cause significant problems for the student. And this is something that Dr. Borowitz mentioned this morning. It's a certain drug called vincristine can damage the nerve cells, the nerve cells in the periphery, in the hands and feet. And there can be a loss of fine motor control, or there can be a loss of the sense of touch with sensory neuropathy. Accommodations for this type of late effect would be physical or occupational therapy. If the student is having difficulty with their fine motor control and unable to keyboard or write, the student may need extra time for writing assignments. They may need a voice recognition software to help so they could dictate. There's orthotics that can be used for the hands or feet. These students should avoid temperature extremes because they can trigger tingling and numbness in the fingers and shooting pain in the feet or hands. Some students are on pain management to control the shooting pain that occurs with peripheral neuropathy. And depending on what their regimen is, they may need to take pain med during the school hours. Neurogenic bladder is another invisible late effect that students can experience. And this occurs when nerve damage has occurred that affects the bladder's ability to fill and hold urine and urinate. And what usually happens for these students is they have to have reconstructive surgery to allow a passage for their urine to exit the body. We see this type of late effect in students who have had tumors or surgery of the spine. And you can see in this diagram that there's different varying degrees of the severity, but in all cases, the tumor is close to the spine. The reconstructive surgery occurs when involves using a piece of intestine connected to the bladder that is attached to the surface of the abdomen with a stoma. And this stoma is the opening that the student inserts a catheter into so that they can empty their bladder. This catheterization needs to occur every 2 to 3 hours. So students should have this break built into their day. They should also be able to have unlimited access to the school nurse in case there's problems with leaking. And when they need to go to the school nurse, it should be upon first request. for the intermittent catheterization or if leaks occur. It will be very important to make sure supplies in the school clinic are conveniently accessible for the student, and there should be an arrangement with the family that for monthly refilling of supplies, including a change of clothes. This is usually this occurs in infants or toddlers. So this is something that the child has grown up with, and they're not always aware of the odor of leaking urine. So it would be important to come up with a code word that maybe the family already uses, or set one with the student so that you could let them know if there's a odor of urine that the student may be unaware of. They have lost sensation from in their below in the bladder area, and they may not feel dampness if there is leaking. Invisible late effects continued with fatigue. And there are many sources of the fatigue that occurs in students with late effects. They could be of an endocrine source with adrenal insufficiency or low cortisol levels. It could be because of low testosterone. It could be because of low estrogen, and the student is actually going through menopause and having hot flashes at night, not able to sleep. It can also be caused by hypothyroidism. These endocrine deficiencies are typically the result of radiation to the brain that has damaged the pituitary. Fatigue can be because of organ dysfunction. These students could have been treated with anthracyclines, a class of chemotherapy that affects the heart, and they develop symptoms of congestive heart failure early, so that would include the fatigue. They may have pulmonary dysfunction from specific chemotherapy or radiation to the chest, or they could have, if they have an amputation or a prosthetic, they may be tired from just using crutches all day. They also could be having fatigue because of poor sleep. We know that brain remodeling occurs in students who were treated for brain tumors and acute lymphoblastic leukemia, and that includes insomnia. Poor sleep could also be because of mental health issues. These students have anxiety, depression, PTSD. So there's many reasons that can contribute to fatigue. Accommodations for fatigue would be having a conveniently located cubby for younger children or a locker for middle and high school students, having a set of books and material already in the classroom for these students, and an extra set of books and materials at home. Allow the student to self-regulate their PE participation. Offer them modified PE. Build in rest periods during the day. Allow them to have water and snacks as needed throughout the day. And even a modified school day so that the student can attend school during their most energetic part of the day. So As you can see, there are several physical late effects that can impact school performance and the satisfaction with attendance. These late effects are clinically obvious to classmates. Some are clinically invisible to classmates, but either way, these late effects use up emotional energy that the student, that takes away from the student's ability to focus on school. So this emotional burden is significant. And the more we can help the student accommodate these handicaps or hurdles, the better their school experience will be. The student's interpretation of late effects and what accommodations they need may be different from what their parents expect or what teachers and counselors expect. So it's important to get the students' feedback for what type of 504 or IEP accommodations to make. Don't underestimate the value of normalcy and structure provided by attending school, even if it's on a modified schedule. And the need for accommodations to succeed academically does not end at high school graduation. There's over 100,000 childhood cancer survivors in college, and they may need your help preparing for accommodations in post-secondary education. So, any questions?
We have a question that came into the chat, and this, I'll ask you, Evelyn, but Lauren, when she presents on educational plans, oh, she says, never mind, you just answered it. So say Lauren will speak to it when she talks about educational plans as well. Any other questions? I love that you kind of bridged between physical and the social emotional late effects, because as you were speaking, I was like, man, all of these physical late effects have to impact mental health significantly. Have any questions? We'll wait just another minute to see if anyone else, you can type your question in the chat on YouTube and I will ask Evelyn. I don't think we have any coming in. Thank you so much, Evelyn. It's very eye-opening just how many potential physical late effects there can be from cancer treatment for these children.
Thank you.
Thank you so much. We will take a very quick, not really a break. We're just going to get our next presenter on. We'll be right back. So don't go anywhere. All right, our next presenter is Mandy Tribe, Educational Consultant for Children's Hospital of the King's Daughters, or CHKD. Mandy has 42 years of experience as a special education teacher, 13 of which were with the state-operated school program at CHKD. Mandy will share about the cognitive challenges of childhood cancer survivors and how to recognize when a child may be experiencing this late effect. Welcome, Mandy.
Thank you, Susan. Good morning, everyone. As Susan mentioned, I am, there we go, an educational consultant. We are a rare breed in the area of education. We are scattered around the country in various hospitals. Here in the Commonwealth of Virginia, there are more of us since, I'm going to do a little plug here for ASK, since ASK did get the funding to have more educational consultants in different facilities across the Commonwealth. A little bit about my background. I got my undergraduate degree in special education at the University of Birmingham. That would be in England, not Birmingham, Alabama. And my master's degree at George Washington University in secondary education transition with a concentration in brain injury. I'm actually a certified brain injury specialist through the Brain Injury Association of America also. Just a little bit about Children's Hospital of the King's Daughters. We are the only freestanding children's hospital in the Commonwealth, and the clinic where we serve our patients who are diagnosed with cancer is actually referred to as the Children's Bleeding Disorder and Cancer Center, Children's Cancer and Bleeding Disorder Center. We have over 500 cancer patients. We have about 60 patients diagnosed annually, and there are approximately 250 patients in our intact clinic. That is either can be referred to as our late effects or survivorship clinic. And intact actually stands for individuals thriving after cancer treatment. I do want to make a little comment. I don't have a lot of information on my slides. They're quite clean. I don't like a lot of clutter. So if you miss anything, if I speak too quickly or you don't understand the accent going on here, just please let us know in the chat box, and I can just rephrase or repeat what I said. And I'm always willing to share extra resources after we're done today. There will be times for questions at the end. Feel free to ask as we go along. I have no problem pausing just to respond and chat as we go along. So starting off with the risk factors for cognitive late effects in our patients. There are some treatments for pediatric cancer that can increase the risk of cognitive late effects, which are basically problems in how a child or even adults, how they think, how they learn, how they plan, how they solve problems. These late effects, these cognitive effects, can be mild or severe. There is a continuum of problems here. And they may be temporary or unfortunately may be permanent in some of our patients. Brain surgery obviously can have a significant impact to learning. Radiation, particularly radiation to the head, to the neck, or even the upper spine, as has been mentioned previously today, I'm sure, really can result in some significant cognitive concerns. We also have certain chemotherapy medicines that are administered to our children that pile on the concerns that we have with learning. Corticosteroid medicines are often given during treatment, but the effect of those kinds of medications are usually mild and for the most part pretty reversible. Research has found that females who are treated with cranial radiation are actually at a higher risk for cognitive late effects than their male counterparts, unfortunately. Radiation that is administered at an early age can have can put our children at an even greater increase for cognitive late effects. And this is because normal brain cells are growing really quickly, as we all know, in those first few years of life. And that puts them very much at risk and very sensitive to the radiation that will be administered to them. Physicians really try to avoid using radiation therapy to the head or spine in children younger than 3 years of age to limit that damage that might affect brain development. Even in older children, we see that radiation can cause some learning problems as they age and progress. Obviously, our physicians are trying to use as little radiation as possible when they're coming up with the treatment plan for our patients, but the needs of the child and the diagnosis and the prognosis obviously have to be balanced with the risk of the cancer growing or returning. So radiation therapy may have to be used as a life-saving treatment in some cases. So on my slide, I have something that says ITMTX. That actually stands for intrathecal methotrexate. And Evelyn mentioned that in her presentation a few minutes ago. Methotrexate is a chemotherapy that is used for various types of cancer, such as acute lymphoblastic leukemia, brain tumors, non-Hodgkin lymphoma, osteosarcoma. IT stands for intrathecal. That is when medication is basically injected into the central nervous system, and it does travel up to the brain. Now, there is something called a blood-brain barrier that is intended to stop toxins from crossing into the brain and having an impact on the brain's ability to function. Methotrexate doesn't care about that. It will cross the blood-brain barrier, and that is one of the red flags that we have for monitoring our children as we continue to see them in our late effects clinic. If they had one of the big red flags, if they've had intrathecal methotrexate. Another treatment that puts students at risk for learning difficulties later on is bone marrow transplant. This is a significant treatment when sometimes children may have relapsed or they have a certain type of cancer. Another big red flag for keeping an eye on our children's educational progress. So any and all of these treatments can interfere with the white matter development, generally in the frontal lobe. And we all know as educators, the frontal lobe is so important for learning and planning and inhibition control. So when that white matter is has been impacted, then we have these cognitive impairments that can become more noticeable over time as that frontal lobe grows. It can also impact some of the gray matter in certain brain regions, such as the hippocampus, which is a structure involved in memory formation, and that is particularly sensitive to cranial radiation. Survivors can also develop other chronic health conditions, such as heart, lung, or endocrine disease, and those types of late effects can also put the patients at risk for cognitive problems. Overall, the intensity, such as the dose and the treatment, the duration of treatment, and any medical complications such as stroke, hydrocephalus, infections, or seizures add to the significant risk factors for cognitive late effects. We also have other treatment-related factors that can impact cognitive functioning indirectly. These can be things such as hearing or vision. In fact, there is another chemotherapy medication called cisplatin that can cause hearing problems. So we have to monitor our patients' hearing abilities with audiograms on a regular basis to check on their hearing. Missed school. As we know, absences from school can have a significant effect on our children's learning, and emotional or social issues. A lot of our children, and I believe once again, Evelyn, in the previous presentation mentioned the emotional impact of the physical late effects, but just going through treatment in itself can cause significant emotional concerns and social issues. The ability of these children to form relationships with their peers, to maintain appropriate relationships with their family also. So all of these things, as we know, can impact learning. So recognizing cognitive late effects. It's not that easy, unfortunately. They usually show up within a few years of treatment. However, they can show up 10 years or more after treatment has ended. And that can really complicate matters as an educator as to figuring out what's going on with your student. I frequently will have parents call me and tell me that the schools are not aware of the late effects of their cancer treatment. The parents will try to explain to the counselor or the teacher or the administrator and say, well, my child is a cancer survivor. They've had all of these treatments and this is impacting their learning. And a lot of times, because obviously a lot of schools are not aware of this, they'll respond and say, but your child's not on treatment anymore. Well, no, they're not, but they are experiencing these late effects in school. So what kind of difficulties might we be looking at? So generally a loss of function compared to previous abilities, or a lowering of function compared to what could be considered age or developmentally appropriate. For most of our childhood cancer survivors, we're not looking at a loss of skills. It's more a slower rate of learning compared to their peers. They can still learn, they can still develop their skills, but just not as quickly as their classmates. Cognitive late effects are often related to problems in executive function, getting back to that frontal lobe where all of those executive function skills come from. We're looking at working memory, flexible thinking, self-control. These are the skills that enable the child to plan, organize, problem solve. We see a lot of deficits in attention, processing speed, and the ability to organize and complete tasks. The American Cancer Society notes that nearly any area of brain development can be affected by cognitive late effects. It's interesting that nonverbal skills in math are more likely to be affected than language skills like reading or spelling, but it's not exclusive of those skills. We do see that problems might become more noticeable during key times of academic transition, starting kindergarten, moving from elementary to middle school to high school, even high school to college. As children mature, we as educators and parents, even grandparents, we expect our children to become more and more independent in their organization, applied learning. But children with these cognitive impairments, it gets more and more difficult for them. The increasing demands become harder to manage. We expect them to be more independent, like I said, and we look at them and say, well, you're in high school now. You should be able to do A, B, and C. And it's just not possible for them to complete those kinds of, or meet those kinds of expectations. As I said earlier, it can be difficult to identify these kinds of late effects, particularly in adolescence. Very often, these kinds of difficulties are put down to typical teenage behavior. Well, she's just not paying attention. He's distracted by other things. He's lazy. She doesn't really want to apply herself. I have a whole list here that I can go through of things that are maybe red flags. We have organization, completing tasks, staying focused, lack of long-term concentration, frustration with school, planning, impulsivity, learning slower than their peers, loss of interest, school-related anxiety. Very often we try to figure out, well, why is this child having anxiety in school? Is something wrong with going on in the family? Did they not make the soccer team or the dance team? It may be because they are a childhood cancer survivor. General delays in reaching developmental milestones. Sometimes we see a lowering of IQ scores. Obviously, that's going to vary depending upon the intensity of the treatment. Sometimes poor hand-eye coordination, behavior problems also. And again, that's such a myriad of problems that we need to be on the lookout for on a regular basis. Managing these cognitive late effects, obviously, like any other student with learning difficulties, there's a continuum of services available. Often a Section 504 plan can address the student's needs. A lot of our patients have a 504 plan while they're going through treatment. So many of our parents are aware of what that is. And they're generally quite comfortable looking into eligibility again if they see that their child is having problems later on. Or in some cases, some of them still have the 504 plan and we just make amendments to that. If the 504 is not providing the appropriate support, obviously we're going to want to look into something more in depth, such as eligibility for special education services under IDEA. Generally, if our patients are found eligible, they do qualify under the category of other health impaired. Now, here in Virginia, just back in 2021, the eligibility for a traumatic brain injury was changed. It used to be that it was only a brain injury resulting from an outside force that could qualify a child under that category. That actually the criteria was revised to include strokes, brain bleeds, aneurysms, and brain tumors. So now our children who have brain tumors can be found eligible under the TBI umbrella, which personally I feel that is much more appropriate because it is basically a brain injury. Another important resource that we use is our neuropsychological evaluations. We have neuropsychologists that we refer many of our patients to on a regular basis. Most of the schools I work with in our area here in Hampton Roads do not have neuropsychologists. So these evaluations are very helpful in identifying the needs of our students. They are actually more broader and more in depth than the psychological evaluations that are usually completed by the schools. Mainly because they actually examine brain functions and skills rather than what does the child know. Managing cognitive late effects can also include things such as brain games. There are so many apps out there nowadays that can be used, even for some of us who might be getting a little up there in age, such as Lumosity, Elevate, Peak, CogniFit. Learning new skills, doing puzzles, playing games that involve memory or logic can improve brain health. It's just important that these games or activities progressively challenge the child so that the tasks get harder as skills are mastered. Physical exercise is important for everyone, but in particular, our children who are cancer survivors, and it can help improve brain health and cognitive function. Being active promotes the growth of brain cells, and it can also help manage stress and anxiety, even depression. It also improves the overall health and fitness because of all the other late effects that some of our patients could be experiencing. There are therapy-based interventions that can also help our survivors address weaknesses. Therapists can help the patients use their strengths to cope with any limitations and address specific needs for generally a personalized approach to their care. Some patients will benefit from medication, such as stimulant drugs for ADHD. Sometimes our families are a little loath to go that route. They will often say to me, my child has had enough medication. We've been through enough. We really don't want to go to that unless we absolutely have to. But it's always an option there for our patients to utilize. Very often, it's more appropriate for that kind of medication to be monitored by the PCP or the pediatrician, because in our intact clinic, we only see our patients once a year. So that's just not appropriate for our physicians to be doing that. So basically, some takeaways for how to support your childhood cancer survivors in the classroom. It is so important to have documentation somewhere in the child's records. As I mentioned at the beginning of the presentation, these late effects can show up so many years later. So helping identify the root cause of why these children are having problems is so important. Knowing the diagnosis and the type of treatment they received. Our intact patients receive a copy of their treatment plan that can be shared with their PCP and can also be shared with a therapist or their school. For instance, excuse me, in some of our treatment plans, something such as this might be noted. CNS-directed therapy, placing Mandy at lifelong increased risk for neurocognitive sequelae, which can be progressive even beyond 10 years from completion of therapy. Currently, Mandy is an excellent student in school, but could use some additional assistance in mathematics, which is being taught virtually at Norfolk High School. She was seen by our educational consultant, and we will continue with monitoring of Mandy's academic progress. She has never had neuropsychological testing performed. So something like that would be such a great resource to have in the school records for your cancer survivors. So those takeaways, and just always please be open to the concerns of the parent if they come to you and say, my child is a cancer survivor. Thank you for your time. And do we have any questions, Susan?
We do have some questions. So how common are cognitive late effects?
Oh, goodness. I feel like I should have some research in front of me. Probably, I would say out of my patients, maybe at least 50%. I think some of the research is saying more than that. As treatment is becoming more targeted to our patients, I know they're trying to provide less and less treatment that is going to cause cognitive late effects. And it is a continuum. We might have some students who have some attention problems, and then other children who have been significantly impacted, particularly our brain tumor patients.
I think that you answered this question, but I just want to make sure.
Okay.
Would ADHD meds help with the executive functioning issues?
Yes.
And then our last question is, how important is it to have an end of treatment neuropsych evaluation of the child to have a baseline to identify late effects in the future?
It is very important. We try to refer as many of our patients as possible. Unfortunately, we do not have our own in-house neuropsychologist. That would be wonderful. But we do have two amazing neuropsychologists that we do refer to, one of who actually used to work in the school system. So she knows what the schools are looking for. And I'm not sure if I mentioned, not only do they identify the problems, they are really, really good at giving suggested accommodations that are user-friendly for the schools, for the eligibility committees, for the IEP teams, for the 504 teams also.
I'm going to go back to the ADHD question. So to add on to that, would ADHD meds help even without an ADHD diagnosis? So it's kind of like, is it late effects? Are late effects mimicking ADHD? Do they need a diagnosis of ADHD to start ADHD meds? And then this is probably a parent question, should they pursue ADHD meds during or after treatment?
I think most providers are going to want an ADHD diagnosis. before prescribing anything. What was the second part? I'm sorry.
Can they start or should they start ADHD meds during or after treatment?
I'm trying to think if we've had patients having it on treatment. I don't believe many of our providers prescribe it during treatment. I think they prefer to wait until after treatment is done, and then just to see how the late effects are impacting.
Okay. I'm going to save the 504 question for our educational plan session that's coming up. I'll do one last question and then we're out of time. So would you recommend the neuropsych eval outside of or in the school? Like from
But if you have a neuropsychologist to refer to, it really doesn't matter. As I mentioned, the school systems I work with, for the majority, do not have neuropsychologists in-house. That's why we refer private.
And so would a parent, if they're not at CHKD, say they're at another treatment center, the child's at another treatment center, are those neuropsych recommendations, do they come, who in their treatment center should they ask for a recommendation to?
You should be able to ask the provider, social worker, either of those. If they go to see a neurologist, a lot of our patients also see neurologists, so they would be able to help with that also. Now, if you don't have a neuropsychologist that they can be referred to, then, you know, obviously go into the school to have a complete evaluation done there and have their school psychologist do their evaluations.
Okay.
Okay.
Great. Thank you so much, Mandy. This was a wealth of information.
I try. Thank you.
We are going to take a quick break and we will be back at 11:15. All right, welcome back, everybody. Our next presenter is Dr. Amanda Thompson, Chief of Pediatric Psychology and Director of Pediatric Programs at Life with Cancer, the psychosocial program of Anova Shar Cancer Institute. In addition, she currently serves as the chair of the Pediatrics Adolescent Young Adult Special Interest Group of the American Psychosocial Oncology Society and has a leadership seat on the Pediatrics Council of the American Academy of Hospice and Palliative Medicine. Prior to her current roles, Dr. Thompson spent a decade as the Director of Psychology and Psychosocial Services in the Center for Cancer and Blood Disorders at Children's National Hospital in Washington, D.C. Dr. Thompson will speak on the silent struggles of childhood cancer patients and survivors, the social-emotional late effects of treatment. Welcome, Dr. Thompson.
Thank you so much, Susan, and good morning to everyone. Thank you so much for having me here today. First and foremost, I have to say that speaking about the social and emotional impact of cancer treatment in children and adolescents is really a giant topic to cover in 30 minutes. So I'm going to try to do it justice, but I'm very much going to ask for some forgiveness in that I'm only able to cover so much. There we go. Okay. So as you've probably now heard at this point, each year in the US, more than 16,000 children and adolescents are diagnosed with cancer. And while cancer remains the leading cause of death by disease in children, there are nearly 500,000 survivors of childhood cancer in the US today. This is great news and certainly a testament to advances in treatment, but it hasn't come without a cost, as over 2/3 of survivors experience one or more physical, neurocognitive, or psychosocial late effects of cancer that may impact their quality of life. And we're going to talk about some of those today. But before we dive in, I want to take a step back and have us reflect on the complexity of the cancer journey. And this complex figure here doesn't even begin to do it justice. Treatment can last anywhere from a few months to many, many years. Some treatments are mainly outpatient, some are mostly inpatient, some are a mix of both. But it's all complicated, disruptive, full of uncertainty, transition, challenges, ups and downs, and so much more. And this cancer journey for our patients disrupts all the normal things a child or adolescent is supposed to be doing. One of those normal things, or perhaps the most normal things, is school. So while I can't talk about all the social emotional effects of cancer treatment today, I hope to give you an overview and focus on those that have particular relevance for an impact on the child's ability to return to, function in, and enjoy their school environment. It goes without saying that a child's diagnosis of cancer is life-changing for patients and families. And as family functioning directly impacts a child's functioning, I have to start there. In the blink of an eye, when a child is diagnosed with cancer, parents and caregivers are asked and expected to absorb piles of complex medical information and to make treatment decisions very quickly, while also trying to manage their own emotions of shock and confusion and the reactions of their children and their families. They have to witness and support their child who may be in pain, who's undergoing painful procedures, surgeries, as they're now fighting a life-threatening illness. They're experiencing sudden changes in routine, making decisions about their jobs. As 30 to 50% of families, at least one parent quits their job to provide care for their sick child. So that brings with it new financial implications, new financial burden. Parents are having to figure out and manage insurance, FMLA, financial stuff, medications, appointments, how to communicate with their family and friends and community and the school, and somehow also support their healthy siblings. Your students, now our patients, are pulled out of everything familiar to them. They're thrown into foreign, unfamiliar, scary environments. Everything that mattered to them, everything that they're involved in stops. Just put on pause. They're undergoing painful procedures. They're having surgery. They're being asked to take lots of medicine, many of which don't taste good, don't make them feel good. They're experiencing fear and worry and confusion and discomfort, all sorts of emotions, and faced with so much uncertainty. And while I won't have time to focus on siblings today, that's a whole separate talk in and of itself. We know that they suffer and struggle too, and you may have some siblings in your classrooms. They have concerns and fears for their brothers or sisters. They're in the thick of the disrupted roles and routines within their family, now having less contact with their brother or sister and with their mom or dad who may be at the hospital for extended periods of time. The older kids in particular may have added responsibilities and expectations at home. Siblings are wondering, who's going to stay with me? Who's going to pick me up? Is my brother or sister going to be okay? Are they going to die? Why do they get all the attention? Am I being punished for something I did to my brother or sister? And in some cases, siblings are also being called upon to serve as a donor for a stem cell transplantation, which can include all sorts of ethical or other psychosocial concerns. So beyond this descriptive introduction, we have decades of research that document the impact of a cancer diagnosis on the psychosocial functioning of children with cancer and their families. What we have learned is that children are incredibly resilient, and that because of that, most kids adapt and cope quite well. There are a wide range of coping strategies that they use and that work well, and there isn't a single best way or a one-size-fits-all that I'm going to tell you about this morning. We do expect there to be some short-term distress reactions at various time points along the cancer trajectory, certainly at diagnosis, at any moment of relapse or recurrence, and also during that transition off treatment. We know that family distress, so with parents and caregivers and the patients themselves, it's typically highest at diagnosis, and then it generally returns to baseline over the course of that first year of treatment. So while most children and families are resilient and do quite well, consistently, there's a small but significant group, about a quarter to a third, who don't cope quite as well and who experience significant levels of psychological distress that may require intervention. And there are factors that have been identified, like diagnosis, treatment intensity, prior psychosocial functioning, family factors like family conflict, financial stability, levels of psychosocial support, other concurrent stressors that we know impact adjustment during treatment and can contribute to more or less distress or that family's ability to cope. We also know that there are a wide range of typical and natural social, emotional, and behavioral reactions to life after treatment. These are expected and important to consider and know about. So our early and long-term survivors may experience things like excitement and hope and relief, but at the same time, they may experience distress and worries and anxiety. They may experience some hypervigilance around their bodily symptoms, where now every bump or bruise or ache or pain is something to be worried about or feels like a warning sign, because they're frequently thinking about cancer and their cancer experience. And fears of cancer recurrence are incredibly common. And this is not just for the patient, but very much for the parents as well. There's something called scanxiety that comes up, and this is the anxiety that surrounds the maintenance scans that have to happen, the MRIs, and the tests and procedures that come up. A lot of concerns about the future, particularly when it comes to dealing with those late effects. A lot of uncertainty about the future and what that's going to look like and what that means. There's an emotional fatigue and exhaustion of having gone through what they've been through the last several years. There's still a lot of emotional processing that has to happen. There can be a loneliness and a social disconnect, and we'll talk about that in just a bit. There's some difficulty returning to school or college or work or life activities. There can be some survivor's guilt in having survived a disease that maybe some of the friends that they've met along the way were not able to survive. Questions can come up, those bigger existential questions about life and meaning. And often along the way, in processing everything they've been through, our survivors can find meaning in their journey. When it comes to psychosocial late effects, we know that survivors are at risk for a range of psychological symptoms, including anxiety, depression, post-traumatic stress symptoms, low self-esteem, and somatization. Somatization is when we're experiencing psychological distress as physical symptoms. And it seems that being diagnosed in adolescence in particular increases the risk for many of these concerns. Research also shows that survivors experience a number of social challenges, including more social isolation and social anxiety. They're less accepted by their peers and participate in fewer social activities. Brain tumor treatment in particular often results in challenges in the area of social competence, with survivors of pediatric brain tumors demonstrating trouble with social awareness, reading social cues, and social problem solving. And as you can imagine, this has particular implications for peer relationships and peer acceptance in and out of the school environment, and also for future romantic partnerships. Now, you've just heard about the cognitive impacts of disease and treatment, so I'm not going to spend time here, except to emphasize that neurocognitive late effects, like the ones listed here, while obviously impacting academic performance, also contribute to emotional distress. Things like anxiety in the education environment, ability to perform academically, but also to low self-esteem and more. I'd be remiss if I didn't mention the education outcomes, because again, those contribute to emotional distress in those environments. We know they're both direct and indirect effects of disease and treatment and that impact academic progress. The rates of absenteeism are actually about 4 times higher for children with cancer than the general school-aged population. In addition to the cognitive impacts, fatigue and other side effects are making it difficult for survivors to concentrate and keep up. We know that survivors are more likely to repeat a grade, which is not unexpected given the above. And they're more likely to use special education services, which I actually think is a really positive outcome, given that we want and encourage all of our patients and survivors to have and utilize IEPs and support services. And lastly, studies show a relationship between more neurocognitive impairment and lower educational achievement overall in our survivors. And that, unfortunately, not unexpectedly translates to less full-time employment in adulthood and less household income. And all of those outcomes are related to psychological outcomes as well. Sorry. So when it comes to school reentry after diagnosis, what do we know? Researchers and clinicians agree that a return to a student's school can facilitate a sense of normalcy, improve health-related quality of life, and promote positive adjustment, academic progress, and socialization of the child or adolescent with cancer. So this is the good news here. And because of that, children with cancer should return to their school and the community as soon as they're medically able. Although it has to be said that there is considerable variability between individual providers and across oncology programs regarding what constitutes a timely return to school. And in addition, return to school is very much dependent on family comfort, as that's quite variable as well. Because there can be some challenges, and the child and family and teachers and school systems are likely to need some guidance, school reentry support has now become a standard of care in the field. School reentry can happen at various points along the trajectory. So we're going to take a minute to look at that return to school from the student's point of view. Early on, when a student is out of school around the time of diagnosis and the beginning of treatment, they're often out for an extended period of time, perhaps on homebound or receiving services within the hospital school program. They're missing class, potentially falling behind. They're also missing sports, activities, school-related events, maybe some of those major milestones. They're missing their friends and opportunities for socialization. Moving forward in treatment, more towards the middle of treatment, pushing towards maybe the end of their more intense treatment, they may return to school at certain points, but there's going to be frequent absences, perhaps for regular appointments or maybe admissions for fevers or other side effects. Your student's going to be excited to go back to school, but probably also a little scared, a little worried about what that's going to be like after being out for some time. They're probably going to struggle to keep up as side effects are still common and interfering with their day-to-day. They may get lots of attention from their peers, which maybe will feel nice, but also could be uncomfortable and awkward. And we hear that a lot from our teens, that they actually don't want to stand out, and that doesn't feel so great. They're also trying to reconnect with their friends that they've been apart from for some time and figure out what they've missed in that social space. And it's not uncommon for teachers to kind of go easy on them when they first return. Coming off treatment, making that initial transition off treatment, it's an exciting time, but it can also be really scary and kind of unsettling as it's sort of trying to figure out what the new normal is going to look like. So they're returning to school, and at the same time, maybe now there's less attention from friends, and perhaps even less understanding from their friends and maybe even from their teachers. And because of all the missed time, they're struggling to reconnect with their peers, struggling to catch up. They feel behind and maybe even a little lost. And finally, during that survivorship period, we see students struggling again with their peers, struggling to feel connected, and really now dealing with the long-term physical and cognitive changes, which are really starting to impact their academic, social, and emotional functioning. So overall, what we know is that a timely return to school is recommended, but reintegration is going to be difficult for some students as social, emotional, and academic challenges are common, especially for those that are diagnosed in adolescence or with brain tumors or diseases that impact the central nervous system. Being a patient or survivor can feel lonely. While they're trying to get back to normal, they feel and look different. They stand out and they just want to fit in. They may not be able to participate in some age-appropriate activities and may struggle to keep up physically, academically, socially. And because of all this, they will need your support. So in the last handful of minutes here, I want to talk about that and how you can support your students' social, emotional, and behavioral needs, and by extension, their parents and families. And first, I'm going to remind you to consider the whole picture, right? Cancer is one piece of that picture. It's a big piece of the picture, but it's one piece. And there's some developmental considerations. How we support a child must involve consideration of their developmental stage and needs, as certainly you all know that the needs for a 4-year-old are very different from the needs of a 14-year-old. We also know that disease and treatment can impact the course of development. And because many of our patients' treatment can span many years and therefore many grades in school, those needs are going to change over the course of development. We have to think about those transitions, right? If a patient is in treatment for many years, that might include the transitions from elementary to middle school or from middle to high school, where those needs are going to look very different. Another piece of the puzzle or the picture is the family system. Cancer doesn't happen in a vacuum, and it impacts the entire family. How the family is functioning impacts the child and vice versa. You all know that when a family is experiencing upheaval of any sort, a child brings some of that stress with them to school. So cancer is very much going to exacerbate pre-existing family stressors, and some families are better equipped to manage new stressors. They may have more resources and supports, and others may be more under-resourced, have less support, and are going to feel that stressor more intensely. Certainly, as you all know, one of the keys to engaging in a collaborative and productive teacher-family relationship is communication, and that's very true here as well. As consistent with the standard of care in school reentry, I'm going to encourage you to open a line of communication with the healthcare team, certainly as the family allows, as consent is needed, and then to check in regularly with the student, the parent, and that healthcare team. One of the simplest things you can do, and this is especially helpful for our teens, is to ask. Ask how your student wants to be supported. Teens, as you know, have very strong opinions about most things, and they will tell you. They will let you know if they just want to be treated like every other student, or if they need a little extra time getting from class to class, or if they need a break throughout the day, or something else. I think it goes without saying that you have a powerful influence on these children's lives. So having empathy, listening, and validating your students' emotions will be so powerful, especially during those tough days and moments of frustrations. I want to encourage you to avoid those phrases that can unintentionally feel quite invalidating, that don't cry or don't worry, or phrases that just aren't true, like I know how you feel, or that we can't guarantee, like it will be okay. And instead, just use simple statements like, this must be so frustrating. You've been through so much. Or my favorite, tell me more, as that helps just reinforce having more conversation. The school environment overall helps to support a child's sense of normalcy, routine, and structure, which is so helpful during a time when everything really feels quite abnormal and unpredictable and unfamiliar. While your first instinct might be to throw all academic expectations out the window, I want you to consider that that can be really destabilizing for children and even a little scary. Reasonable expectations are actually helpful as they help to reinforce that sense of normalcy. I had a teenager once tell me that her one teacher who graded her English assignments the same way she did before her diagnosis gave her hope that not everyone had given up on her having a future. Given the social challenges we discussed, think about ways to foster inclusion and celebrate diversity in all its forms, and ensure that your school has a zero tolerance when it comes to bullying. As you now know, some patients will struggle more significantly and need additional support. So be on the lookout for social, emotional, or behavioral stress that is really impacting a child's functioning, happening sort of so often, more often or more intensely, that it's impacting a child's functioning, their school performance, their ability to participate in school or activities or engage with their peers, something that really feels different than the child that you have gotten used to. So this might look like a young child that is showing signs of severe separation anxiety when their mom tries to leave school. Perhaps a student who reports stomach aches or headaches before every test, quiz, or recess or gym class, or something else. A teen who stops engaging with their peers, sitting alone at lunch, not interested in the things that they used to enjoy. These are the kind of red flags that we look for, the signs of distress that let us know that more intervention is required. Additional supports and interventions also include tending to academic needs through formal accommodations, and obviously you're going to hear more about that. Many students will have IEPs, and I would argue that all should, but I'm going to encourage you to consider inclusion of social emotional goals to support this reintegration and psychological support. Academic testing and tutoring and study skills courses in groups, college and career counseling are going to be important for proper placement and planning for the future. And obviously that all supports that psychological piece as well. For those kids who need additional support and intervention, if your school has the resources, offer individual counseling with your school psychologist or counselor. or provide flexibility for that child to attend sessions outside of the school environment. That may require early departure from class or a late arrival to school in the morning. You can also consider other support needs, like simple check-ins and touch points with a trusted teacher or coach. Depending on what you may have available, consider social skills training options or support. Does your school have social skills groups or peer buddies or similar programs to help facilitate social awareness and reduce isolation? And finally, continue to partner with that healthcare team, as well as local and regional cancer organizations like ASK, to understand what other supports are available for the students. For example, there are virtual and in-person groups for survivors, summer camps for survivors, siblings, and families, and so much more. So as I wrap up today, I just want to reiterate that children and families have ongoing, multifaceted psychosocial needs during and after treatment for childhood cancer. Most children and families will cope and adapt well, but certainly some will have more significant challenges and require a higher level of support both in and out of the school. You are very much a part of the student's care team, and your support is critical to their short and long-term adjustment. So I just want to thank you all for your partnership. The fact that you are here today listening to these talks lets me know just how much wonderful partners you all already are, and I can't thank you enough. So I'll stop there and just see if there's any questions.
All right, while we wait for questions in the chat, give people a chance to type those in. I wanted to ask, I often hear from parents that the transition into survivorship is harder, at least for them as parents, than actual being in treatment. I guess because when you're in treatment, it's just like you're just surviving, you know, and then you make that transition and it's like, now you're dealing with, you know, all the emotions that were there the whole time. Do you find that to be true?
Absolutely. And I think this is something that for a while, even as providers, we didn't really recognize quite as much. We thought, obviously, you know, diagnosis is so hard, but that transition off treatment is really now being defined as a major stress point. And it very much is the case because, you know, while we think of it as an exciting time, treatment is ending, this is so wonderful. Families really experience it as quite scary, right? They've gone for many years with all of the support and reassurance from their physicians, from their care team, their psychosocial team, regular check-ins, regular appointments. And as they transition off treatment, much of that goes away. And the loss of that support, the loss of those regular check-ins, those visits to the hospitals that provide that reassurance to families that things are going well, that their child is continuing to be healthy, can be really destabilizing and can cause a lot of worry. And so absolutely, I think that is very much a stress point. And that really can be a time, I will tell you, definitely in the outpatient therapy setting, we are often caring for parents, providing them additional psychosocial support during that transition time. And as I mentioned, that's also a time where that sort of processing starts to happen. You know, when caregivers are providing care for their child during the active treatment phase, you're often in kind of executive parent mode. You're just going from one thing to the next because that's what you have to do. And then as it starts to slow down, you have to take a moment, and that's when kind of the emotions start to catch up. So, you know, finding some extra support during that time, I think is certainly recommended and can be a really good time to do that. As some of the other responsibilities lessen, it's a really good time to take some time to process everything that you and your family have been through.
We do have a question that came in. This is a great question. Do children who get diagnosed and go through chemo when under the age of 2 deal with these challenges if they don't remember much of it?
Yeah, it's a great question. And so certainly, you know, it's far less from a psychological standpoint. You know, there is a little bit of a protective factor being younger and having, you know, kind of a less of a salient memory for some of these experiences. Now, the caveat is that we know that under 2, if you're having a treatment that is that impacts the central nervous system or the brain, The impact on a developing brain will unfortunately increase risk for cognitive late effects, and so those impacts will look different. And so there could be some social impact of that. Certainly going to be some differences in thinking and learning that could contribute to some psychological challenges in the future. But overall, really, when we think about some of those higher risks for anxiety, depression, post-traumatic stress, much of the research supports that the higher risk is of the diagnosis in adolescence.
Great. We are out of time. Thank you so much, Dr. Thompson. This was very insightful and great information.
Thank you all so much.
Our next speaker is Lauren Kosar, Ask Education Support Navigator, supporting UVA Children's Hospital. Lauren has 13 years of experience as a middle and high school special education teacher and was most recently special education department chair for Western Albemarle High School. Lauren will speak on educational plans to accommodate the late effects and challenges associated with treatment. So we welcome Lauren, and as she gets her slides up, I did see a question that came in that I'm going to ask Lauren at the end of her presentation about who participates in the 504 IEP meetings, and she may cover it before we get to that. So I think she is ready to go. So Lauren, I'm going to hand it over to you.
All right. Thank you, Susan. I am honored to be here today to talk about how to help children and students in kind of the school realm while they're in active treatment and beyond. And so we're really going to focus on the educational plans that are available to your children. And so those are 504 plans and IEPs. Before we delve into that, I do just want to look at, for some reason, my slides aren't advancing. Oh, there we go. Okay. I know that we just reviewed what is a late effect. I don't think it can be emphasized enough to kind of get these this language in our minds, as late effects. Sometimes they look like side effects of when your child is receiving chemotherapy. And then kind of once treatment is done, we call them late effects. And so they really are the consequences of cancer and its treatment. It's really important that we constantly have a surveillance on these and that we are in communication with the school and teachers and educating them about these late effects. Teachers and schools, they didn't go through their education programs to learn about late effects. And so this is probably something new to them and that they may not be aware of. So we talked about the physical challenges. A lot of these will show up again during the active treatment and when they're transitioning back to school, especially that fatigue piece. It's something that we oftentimes really alert teachers to in the school, that even though a student may be done with their chemotherapy, it doesn't mean that they still aren't going to get tired, or sometimes when they are past their intense active treatment, they're still having to get steroids, and that week of steroids can cause some kids to really have some pretty big mood swings. And so communicating to the school about that. And then of course, during kind of active treatment, if they are allowed to go back in school, sometimes they will have some nausea and vomiting. The cognitive challenges, again, that I'm just going to review because I know you all have seen this. The cognitive challenges, they really may not appear until later on in middle school or high school. A lot of the times, kind of that slower processing speed or inability to focus, it'll kind of hit as the academic challenges kind of get increased, and that the students, the children, are expected to do more independently. So these late effects, your child may finish chemotherapy and they may be cruising along pretty well academically, but then they may start to struggle. And so keeping back in the back of your mind that, this could be a late effect. And as Dr. Thompson just went over the psychosocial, emotional piece, I won't really delve into that so much. But I think one of the things that we see a lot, especially in the transitioning back to high school after treatment, is super difficult. And so again, making sure that you are in touch with the schools and the schools really know about kind of I don't want the attention on me. How do I handle all these, all of my friends who have lived, kind of their normal lives asking about me, and how do I kind of fit back into to the whole kind of routine of high school. Problems that used to be problems pre-diagnosis may seem really, simple or silly to your child who's kind of been through isolation and intense treatment. Oftentimes, schools will have a school psychologist there, and of course, school counselors as well that can either provide support or at least recommend support outside of school. So the two things that I really wanted to look at are the two educational laws that are in place to protect students with a disability or impairment. And before going into that, I think it's important to recognize that these are additional labels that that you and your child will need to kind of come to terms with. You've already kind of been through the process of, I have a child with cancer, and so there's that label. And so now there's maybe this new label of your child having a disability or impairment, and different families approach this. Sometimes they approach it head on and they are okay with the labels, and sometimes they have to wait a little bit to kind of process everything before they kind of really are able to wrap their heads around, oh, there are these other labels now that maybe I have to put on my child. But unfortunately, we do have to kind of deal with these terms and look at them. So the definition of a disability. So a disability is a mental or physical impairment which substantially limits one or more major life activity, or has a record of such impairment, or is regarded as having such an impairment. So I think that it's important in that definition to look at two different things, which are what is an impairment and then what is a major life activity. And so if you look at the definition below, it says an impairment is any disability, long-term illness. And so that's really where we capture that impairment piece, is in the term long-term illness, which would be the childhood cancer diagnosis. And again, you have to have that long-term illness that reduces or lessens a student's ability to access learning. And so those really understanding those two definitions are really important. If a person has a disability, we can start to look at the two laws for kids with disabilities so that the school can really meet their needs and move them forward. And so the first law that we're going to look at is Section 504. It's from the Rehabilitation Act of 1973. And essentially this federal law says that school districts, they have to provide a free, appropriate public education. And again, to kids who have mental or physical impairments that substantially limit one or more major life activities. So that's going to be, again, very important in looking at, do they qualify under this law? So Section 504, what it does is it really has widened the definition of kids with disabilities. And it even lists, Congress has listed all the different types of disabilities, but it also says this isn't an exhaustive list. And so we're going to look a little bit more into Section 504. So right here, Section 504, students who have a physical or mental impairment. So again, that physical impairment piece could be the cancer diagnosis that substantially limits, and that's can be kind of a subjective term there, one or more major life activities. And so we've listed here some of the major life activities that that a student with a cancer diagnosis could have. So if a student has had an amputation, then walking could be something that they struggle with. If they have had a brain tumor, sometimes seeing is affected. A lot of the times with chemotherapy, hearing and seeing are affected. With a lot of our kids who are especially receiving treatment for ALL, we'll see kind of it's almost like their major life activity that's impacted is really concentrating, and then that ability to learn and think. And so sometimes it's like a bunch of different major life activities that can be listed. Another thing that Congress actually did was they said that we're going to go beyond just major life activities, but also major life functions. And so one of the major life functions, especially again for children with a cancer diagnosis, is that they don't have normal cell growth. And so they've actually really clearly designated that, children who are in this active treatment, they really do very clearly kind of qualify for these Section 504 plans. And upon diagnosis, again, there's so much that goes on during during the first month or two after diagnosis. And it is important to reach out to the school and really say, I think that my child may need some extra support while they're going through this. So we really encourage parents during that first month or two, even if they don't want to deal with it, to really try to get a Section 504 plan in place for their kiddo, because what we're finding is that eventually through the active treatment, they're going to need some accommodations. The second law to know is called the Individuals with Disabilities Education Act, or IDEA. It was first put into law in 1975, so a couple years after the previous law. And it's been reauthorized several times. I think in 2004, I believe, was the last time. And they've really taken it up a step to prepare children for adulthood. And so there's a whole separate plan called the transition plan that really looks at, well, how are we going to get this child into kind of where they want to be, their independent living skills, their employment skills. Those are all very important things that the school can look at underneath this law, and particularly important for children with childhood cancer diagnosis. If they're older, is really like a goal would be to how to manage their meds, how to make medical appointments. Do they know their diagnosis? Can they figure out what their treatment plan is, or at least know where to go? And so this law has really expanded that piece to really transition them out of that K through 12 environment. Again, this law focuses on you have to have a child with a disability, just like Section 504. It says you have to, the schools have to provide a free, appropriate public education. And again, that's what Section 504 also does. What really makes this law a little bit different is that you also have to prove that the child needs specially designed instruction. And so we'll kind of look a little bit at that next. So again, the IDEA, what it does differently than Section 504 is it really narrows the definition of disability. So with this law, it says there are 13 different disability categories that your child could qualify under. And these are listed right here. And each of these disability categories has its own specific criteria that a school team would have to look at and say, okay, does your student meet the criteria as a student with a specific learning disability? And they would go through that. And not only do you have to kind of meet criteria for this, you also have to then ask, does it impact their academic achievement? And then you have to also answer yes to the third question, which is, do they need specially designed instruction in order to access the general curriculum? So with these 13 categories, if you're kind of looking through them, sometimes children with childhood cancer, it looks like, wow, well, their vision was infected. So could they fall under visual impairment? And what about hearing impairment? Sometimes students with brain tumors, you could look at TBI. With specific learning disability, that slower processing speed could fall into there. And so this can become very overwhelming because it's which category. And so we oftentimes do recommend that actually the second one down, other health impairment, is really maybe something that sums up the whole piece, and that other health impairment would be due to your child's cancer diagnosis. So that's kind of what we steer parents and schools toward as far as one of the disability categories. Some helpful accommodations are these are kind of the main ones that we tend to focus on. Preferential seating close to instruction, and that's really for those kids who may have some attentional issues due to late effects. And so sitting them close to instruction so you can go on up and teacher can kind of tap on the desk and make sure that they're engaged a little bit more. Sometimes they're going to need bathroom privileges. Or even carrying a water bottle to school. We want these kids to stay hydrated, and therefore if they're hydrated more, then they may need to use the restroom a little bit more than other kids. Oral and written directions. So this kind of goes with that kind of that processing speed or even that short-term memory issues. The teacher could provide oral directions, but also putting stuff in writing so that then when the student gets back to do the independent work or home for homework, that they have the instructions written down. One of the big ones too, again, for those kind of attentional issues are chunking of assignments. So we're gonna take this bigger assignment and really break it down one piece at a time. And so it becomes less overwhelming for the student. One of the ones that we use a lot in middle school and high school is that modified workload, especially during active treatment. We often say that, that the health of the child is paramount. And so we want them to be able to keep up with their education as much as they possibly can. But, sometimes maybe instead of doing 10 problems, they can be given 5 that really emphasize the quality of the work and the understanding of the material versus quantity. And then oftentimes with that slower processing speed that could develop, and even when students are going through chemotherapy, is extended time to complete assignments and tests and quizzes. And we have a full educational toolkit on the Ask website that lists 2 full pages of accommodations, and those aren't exhaustive. A lot of the time school teams can be very creative. Sometimes we'll put in a rest period for students who's coming back, especially when they're first transitioning back to school. So that's another accommodation that we oftentimes use. So one of the things in getting one of these 2 plans, the 504 plan or the IEP, is there is a process. And so step 1 of that process is the referral process. Anyone can refer a child to looking at, hey, I think maybe I'm suspecting a disability. I want to talk about it. And so oftentimes we tell parents to go to the child's school counselor and make a recommendation. Say, I think just, I'm seeing some things and I really want to have a child study meeting. Teachers can also refer people from outside agencies, such as Ask. They can refer to the school. And so what happens there with that referral is that the school then has to honor holding a child study meeting to just look and say, okay, let's kind of put our heads together and just see what's going on. So then from that child study meeting, if the team, and it's composed of a team of people from administrators to the classroom teachers, sometimes the school psychologist, and of course the parent, and even sometimes the student. We oftentimes do encourage the student to come if you think that they can handle a lot of adults around a table. But from that child study or that referral process, you really look at, I think that the child either needs to be evaluated to see if they have a disability, or, you know what, we're not seeing a lot of the same stuff, but let's maybe put some different things in place. So then step 2 is really going into an evaluation, which is a lot of different people collect a lot of different data. And they have about 60 days to collect this data. And so maybe that is composed of you going to your child's medical team and saying, you know, can you write up a medical letter just saying, describing my child's diagnosis, their treatment plan, and anything that you recommend that the school should consider. It may be that they need educational testing or cognitive testing, which are both the school can do. It may be that there needs to be a classroom observation. It may be that the parents have to take a survey. And so there's all these different pieces of data that are collected during that time period to really look at, will this child be eligible? So then you get to the 3rd step of eligibility. So that's when the team comes back together in a meeting and everybody shares out the data. And as a team, you really determine, is there a disability? And does it, you know, if you're going 504, does it impact a major life function or life activity? And if you're going IEP, is there disability? Does it have academic impact? And do they need specially designed instruction? And then from there, the team kind of decides all together, yes or no. And then you'll have other meetings after that to come back together to design the plan that's very much meant to fit the child's needs where they are. And last but not least, this is the most important part, is be an advocate. Make sure to tell parents about these processes, and because parents really are the ones that, you know, the school wants to engage them. They want to hear from them. And so parents really need to advocate for their child as much as they can be. And hopefully they will. Oftentimes school counselors are great about really reaching out to the parent and scheduling those meetings, and figuring out, you know, what do we do for these children with who have these late effects or are still struggling during active treatment. And I think that's it. Thank you, Susan.
Yeah, thanks, Lauren. So we do have some questions that have already come in. I'll start with the first. Do we have a sample of a 504 plan template? Is there a template, and where would someone find that?
Sure. So Virginia, they do have a standard 504 template, and you could go to the VDOE site and look for that. I can certainly provide a link, but there is a template that most school systems take and then kind of modify for their own purposes. Like they'll put in their school system's name, but they all pretty much look the exact same, which is what is the impairment, and then you describe it, and then how does the impairment affect the major life activities, and then the last section is really, well, what accommodations are needed for this student in order to support them accessing the general curriculum.
Great, thanks. We'll find that link and we will share it in the chat before the end of the day.
Okay.
So this question, it's kind of a big picture and maybe an outside of Virginia question. So I'll read the question, and then I'm going to address what the education navigators do here in Virginia. But of course, not every state has education support navigators in their pediatric cancer treatment centers. So the question is, with parent permission, of course, how much participation do the doctors, therapists, et cetera, of the student's medical team participate in IEP 504 meetings to help educate the school personnel? So ask education support navigators that are at all of the primary pediatric cancer treatment centers in Virginia. They are the bridge between the medical team and the school team. So they can gather all that medical information with, of course, the permissions given, and then go to the school-based team meeting to partner with the school to make sure that the child is getting the appropriate accommodations. Outside of Virginia, I think that more falls on the parent. can you answer that question, Lauren? I know your experience is here in Virginia.
Yes, I would think that the parent communicates with the medical team, and then the medical team would be in charge of writing the letters. And so I think with the navigators, we kind of take that a little bit off of the medical team's plate. We consult heavily with them when we write the letters and when we talk about what would be good accommodations to recommend to the school. And so essentially, one thing that may be missing between if it's just parent and medical is really that educational piece of recommending accommodations and just having that educational background to kind of tell doctors like, hey, what about this instance that I know about because I've been a teacher and worked in a school. And so that's like the kind of crucial part of the navigators. But yeah, if you don't have a navigator, it's between doctor and parent.
And so that's really where the Ask Education toolkit comes into play. So it was designed before we had these navigators around the state so that, you know, in the other treatment centers, like Children's Hospital of Richmond at VCU has had educational support for a long time. CHKD has had Mandy for a long time, but some of the other treatment centers did not. And so the toolkit is really designed to help parents and help schools kind of to bridge that gap. So it is available. I see the link's been put in the chat to the toolkit. And so that's definitely a resource. We are in the process of updating it. And so what's online is great and is still usable. I think you'll see it updated in the coming months as well. And then another question, what are the options if we are turned down for a 504 or an IEP?
Sure. So a lot of schools, so a couple options. If you are turned down for a 504 or an IEP, but you still really believe that your child has a disability and there is impact on them accessing the general curriculum, then you can basically appeal on the paperwork. There'll be paperwork at the meeting that says, do you agree that your child is eligible or not eligible? And you either put, yes, I agree, or no, I disagree. So that's something that you'll have to make sure to check those boxes. And then from there, you can ask the team and say, I respectfully disagree, and I would like to take this to a different committee. Who should I contact? So that's one avenue. A second avenue is if the school thinks that your child doesn't need one of those plans at the moment, because sometimes schools will put in place and they'll say, well, let me put your child in this reading intervention group for 3 days a week. And it doesn't require a 504, it doesn't require an IEP, but it's extra instruction, it's extra support. Schools have the ability to do that. And maybe it's that intervention that actually starts to move your child forward. And then so maybe you're in agreement with that and you say, you know, I don't think they do need a 504 or IEP at the moment. So oftentimes schools do have kind of like backup maneuvers or intervention systems to help your student. I believe it's pretty rare. I've had very rare case. I've actually had 0 cases where schools have found a student ineligible, especially if they've just had a cancer diagnosis. Very much the schools really want to wrap their arms around the student and want to give them as much support as possible. I think sometimes the trouble can be if those late effects appear 5 years out, and maybe that becomes a little bit more difficult. But again, I haven't had experience with that quite yet. So.
A previous presenter said it this morning, but the other health impairment is what is most often used in those situations. And then one last question, and then we'll break for lunch. Who has the ultimate authority to enforce Section 504?
So if a school receives public funding, the school has to enforce the 504 plan or the IEP. If you as a parent or whomever doesn't think that the school is doing that, then you would call a 504 or IEP meeting and say, you know, here, I don't believe this is being enacted. And if the school says, you know what, we're going to go get back to the teachers, really have a team meeting. We're going to put this in place. Let's revisit in a month. You could go that avenue. But really it is that the school is the one who has to put those in place. And again, there are, kind of like due process pieces if you believe that the school is not putting it in place. And part of it is really working through looking at, okay, well, let's meet as a school team. And if you feel like the school still isn't putting those accommodations in place, then really moving up to more the central office or the school board.
And then one last question came in. Is it important to keep the 504 plan going during all schools? So I think like it can follow someone to college, correct?
Yes, and it can follow them to medical school. And so yes, it is important, and this is where school systems vary. Again, if you're getting the 504 during the active treatment phase, schools are very, they're wide open with that. And even when your student is past the active treatment phase, and if, you know, they may no longer need that reduced course load, you can remove that accommodation and should if they don't need it. And so you can actually have a 504 without any accommodations. And we do encourage schools and parents just keep the 504, even if they don't need the accommodations, because those late effects really could come up later and you already have that plan in place. Other school systems, and this is within their legal jurisdiction, they can reevaluate every 3 years, whether or not is there still an impairment and does it still have impact? And so if there's no impact, then the school could say, okay, you don't qualify for a 504 anymore. So there is that possibility, and it really depends on the school system and how they're going to kind of look at those 504 students.
Okay, one last.
Okay, go ahead.
Question, and we'll go to lunch. Can you talk about private schools versus public schools? And also a child with cancer, I think you did touch on this, being protected under the Americans with Disabilities Act.
Sure. So private schools will oftentimes, private schools, even though they don't necessarily get public funding, they can get funding for speech, and I think sometimes either OT or PT services through the public school system. And so sometimes students can get 504 plans in a private school if there's some connection with, if they're getting so if a private school is getting any public funding whatsoever, then they have to honor a 504. But oftentimes I've seen private schools more do something called an individualized service plan, an ISP. And so it follows, again, kind of like what an IEP does, right? IEP, you have to provide in a publicly funded school. ISP is more the private school version of that. Again, private schools, if they're not receiving public funding, they may say, you know, we just don't have the staff to really, you know, give your child what they need. And then what was with the ADA, Americans for Disabilities Act? So the ADA, so that really encompasses all areas of life, education, workplace, in anything that receives public funding can fall under the Americans with Disabilities Act, and you can get accommodations. So with like a 504 plan, if someone is moving out of the educational realm and into the workplace, they can still present a 504 plan to their employer and kind of say, hey, I need this type of accommodation. And oftentimes those are going to be for physical pieces and not necessarily for those cognitive, I don't believe. So
And then this will be our very last question. These are such good questions there. So, and since we're lunch,
right.
I will go ahead and
keep going.
Yeah. So can you, and you've touched on this a couple of times, but I know it can be confusing for folks. Can you go over the differences briefly between a 504 and an IEP and what dictates needing one versus the other?
So I look at 504 as being an IEP light in a way. A 504 is really looking at accommodation. So my kid needs extended time on test. My child needs a water bottle. My child needs a modified workload. The IEP looks at it and it says, okay, we're going to provide these accommodations, kind of like a 504, but the disability is a little bit more severe in a way that the child needs specialized instruction. So instruction that has been designed with their special needs in mind. So an IEP, I think, is harder to qualify for because, again, that definition of disability is very much narrower. And an IEP is way more intense on the services. That's where you really get special education teachers involved and case managers. And so a 504 is really like, I just need these little accommodations to access the general curriculum. And an IEP is I need accommodations and this really specially designed instruction to access the general curriculum. So that would be, and they fall under two different laws. But that to me is like the overview kind of picture.
Excellent. Thank you, Lauren. All right, we are going to break for lunch. We will return at 1:15. And I thank everyone, and we will see you soon. Welcome back, everybody. Our next speaker is Joe Bauer, Child Life Specialist at Walter Reed National Military Medical Center, who has worked with pediatric patients for the past 12 years. In his work with patients and siblings specifically impacted by pediatric cancer, Joe uses play to both normalize the hospital and to process feelings related to treatment. As an advocate for play as a tool to manage the effects of trauma, Joe promotes play within the classroom to lessen the stress of school reentry after an extended absence. Welcome, Joe.
Hi, everybody. I'm so happy to be with everybody today. And thank you so much, Susan, for that warm introduction. Before diving in, I just wanted to, briefly kind of touch upon what Susan already mentioned. So as a certified child life specialist, I'm providing a ton of normalization in the hospital through therapeutic play opportunities. I'm using different modalities of play to employ distraction techniques during tests and procedures. I'm providing developmentally appropriate education to patients and siblings and just general emotional support for families affected by cancer. And like Susan mentioned, my support, specifically for kids getting back to school is really, really rewarding to me. And I love to be impactful for these patients. So our objective today is to outline the significance of play in human development, to describe the psychosocial vulnerabilities of children undergoing treatment for cancer, to highlight the importance of play for children in the hospital, and to underscore approaches and resources to support patients, siblings, and their classmates. And so while we all know what play is and we see it every day of our lives, I just wanted to give a kind of a formal definition of both play and therapeutic play to give us a theoretical framework and how play specifically benefits kids with cancer. So quick definition of play is any activity in which children spontaneously engage and find pleasurable. So the key word there is spontaneous. So kids are going to play regardless of the resources that they have. Kids will play with whatever they have. It doesn't necessarily have to be toys. And there's an innate desire in every human to play. So quick definition of therapeutic play within the context of the hospital is a framework of activities taking the psychosocial and cognitive development of children into account in order to facilitate the emotional and well-being of hospitalized children. So just of note, so play therapy and therapeutic play often get used interchangeably. But however, we're not going to be talking about play therapy today, as that is a separate discipline that's carried out by a registered play therapist and is used to address a wide range of behavioral and emotional issues that may not necessarily stem from any medical trauma. So what are some of the specific reasons that kids need to play? Well, on a surface level, kids need to play because it's fun, it's amusing, it's enjoyable, it creates bonds between people. But in a more theoretical sense, it's how young children from infancy on, they learn about the world. It shapes their thinking and is the easiest way for them to acquire knowledge at a young age. So play promotes all aspects of development in the areas of language, cognition, social emotional skills, motor skills, and self-regulation skills. Play cultivates key executive functioning skills like planning, organization, flexibility, and attentiveness, which are all integral components when adjusting to adulthood. And one of the best things about play that I love is how it's a universal way of connecting with others, regardless of cultural status and socioeconomic status. And we see the greatest evidence of that in young kids. And from an attachment perspective, play with parents or other caregivers establishes a child's ability to build trusting and nurturing relationships that will determine their capacity to do so as adults as well. So now that we've outlined the foundation of why children need to play, I just want to shift briefly to focus on the perspective of the child in those first few days that they're diagnosed with cancer and how their ability to play is impacted. So I'm not going to spend too much time at all on the medical aspect of things, but I think it's just important to briefly describe kind of what those first few days of the treatment journey looks like. So typically, but not always the case, families will bring their child into the emergency room when there's a suspicion that something more serious is going on. And in the emergency room, that's when kids will always be given some sort of IV access, which will run their blood work. And that's going to be the first medical intervention in a long line of procedures that may cause significant fear and distress in young patients. So these potentially invasive tests and procedures that then follow, many of which children are NPO or have to wait hours before eating and drinking, They're all performed to gather the right imaging and tissue sampling to confirm a diagnosis. And once a diagnosis of cancer is confirmed, it still might unfortunately take several days or even weeks before an exact name is given to the type of cancer. So with or without a definitive name, the next step is for a central line to be placed, which is a special catheter that I'm sure has been mentioned at some point today, that is used to give chemo for the extent of their treatments. And once this catheter is in place, treatment will begin, and each plan will be individualized and prescribed to each patient. So for kids going through this very harrowing experience, multiple different facets of it can be traumatizing for kids. And for most of these kids that are diagnosed, this experience of staying in the hospital is completely new to them. They are feeling completely overwhelmed with what's happening to both their bodies and overwhelmed with the information that's being thrown at them. So for all kids going through this ordeal, there's a degree of personal agency that's always taken away. They're feel completely stuck and they can't engage in the same activities or assert the same control over their day-to-day lives. And this really is its own form of grief since their life has been altered in such a profound way. So during this time that they're in the hospital, they're probably spending a ton of more time with their parents than is typical, and everyone's emotions are all over the place and feeding off one another. So for a lot of these kids, usually school-age patients, cancer has a really daunting connotation to it. Many have had older family members or someone that they know has been diagnosed with an extremely debilitating and had an extremely debilitating treatment battle. And for a lot of these kids that I work with, it takes some major reframing of that word cancer, where we stress that cancer in kids and cancer in adults is very, very different. And we're always going to want to let them know, depending on their developmental level, that nothing that they did or anyone did caused this. It just is something that happened. So when we're categorizing play within the hospital, it shouldn't be seen simply as a recreational activity, but always carries with it a therapeutic purpose. Activities are going to be pre-planned in an organized fashion with both individual and group-based goals. And these goals are always established through an assessment process that I'm always carrying out with every family that I'm meeting. And one example of a goal that I may devise with the patient is to encourage more interactions between that patient and the staff members like nurses or doctors that are taking care of them. And another goal might be to maybe schedule video gaming sessions between that patient and two or more teenage patients. So despite play being the foundation of childhood, kids in the hospital with a new diagnosis, they oftentimes need prompting by people like me to get back to playing and participating in structured activities based on the traumatic nature of the hospital. So it can really dampen a kid's desire to participate in the activities they otherwise find enjoyable. And it becomes my main focus to address this lack of engagement. So within this discipline of therapeutic play that I outlined earlier, 3 subtypes exist. And the first is play that encourages emotional expression. That can be any form of imaginary play, where I'm trying to uncover how a patient feels about a particular subject or experience. This may involve something like using dolls in a dollhouse to invoke how the child is feeling about the relationship between them and their siblings. So the next form is instructional play that's used to educate children. So an example of that is maybe using stuffed animals to reenact a treatment experience that occurred earlier during an admission. And then finally, physiologically enhancing play is using various activities to motivate the patient to engage in physical tasks that will improve their wellness. So one really cool aspect of play is that I always undertake with patients is called medical play, and it can fall into those first 2 categories I described. So it's a strategy that's used by child life specialists to educate on treatment and to elicit feelings related to a part of treatment that may be causing the child to feel scared or anxious. So real medical supplies are used in this context, of course, in a safe manner. And usually a doll or a stuffed animal will be introduced to that child to act as the patient. And that child is encouraged to assume a role as a doctor or nurse. And during this experience, as I'm by their side, I'll be there to both ask prompting questions, but I may also be assigned by the kid to maybe be another doctor or a nurse or some other job within the hospital. So some of the prompting questions I may ask is, tell me about this that you're using, or how is this equipment used to help your patient? So a key part of this should be to encourage kids to make real world connections between their play and their own healthcare experience. So of course, when any kids are in the hospital, there's a lot of barriers that exist, and it's a high priority for child life specialists and other team members to address these issues and then make accommodations. So it goes without saying that kids are going to have limited play opportunities, but it requires an approach by the team within pediatrics to treat play as a standard of care. And this is reflected by literature and publications within the American Academy of Pediatrics. So being isolated in the room, maybe for something infectious or for mobility issues, can be really difficult, especially on young kids. So we try to facilitate as many bedside activities as possible. So when kids are having low activity levels, a child life specialist may actually play for the patient and engage in adaptive play, where that patient, unfortunately, is really only able to watch play because of their medical condition. But within that context of play, we would maximize the degree of choices that child has, maybe by nodding their head or shaking their head to being given a lot of different choices within that play. So social or group play can be really difficult to coordinate when any patients with cancer are in the hospital. So it becomes a big priority to connect patients maybe through special events like holiday parties, bingo in the playroom, or for young kids, maybe toddler circle time. So it goes without saying that treatment in the hospital is always going to conflict with play. But to address that, we often make schedules or we readjust our time for play opportunities by being really flexible. And there's a lot of times a decrease in motivation for kids that are admitted with cancer. So with that, we'll design incentives like sticker charts, maybe dollar systems that can be effective in getting some kids back on track. So now I want to shift to highlight the specific benefits of play for young children that are diagnosed with cancer while they're in the hospital. So first off, play makes kids more familiar with the experience of being hospitalized. When kids are able to play during their stay, they can naturally explore their environments in a way that would be more difficult if they refrain from those normal activities. It allows them to better interpret everything in their hospital experience, and having play interspersed between and during medical interventions helps them better relate to what they're seeing and hearing. So maybe that's something simple like playing Uno right before a CT scan, or putting Band-Aids on their stuffed teddy bear after an IV is placed. So secondly, play allows kids to be active participants in their care. As I said earlier, so much control has been taken away, and engaging in play where maximum choices are offered has enormous benefit to their confidence and resiliency. Really, all kids love choices, but especially kids in the hospital. When kids play with even one medical staff member, like a doctor, nurse, or even a child life specialist, it's going to improve all staff relationships across the board and will usually make the patient put more trust in everyone involved in their care. The play in the hospital is used to teach kids about their treatment, whether it be standard imaginary play or the specific type of medical play with real materials I described earlier. And this really is the bread and butter of what I do as a child life specialist. Every day, I'm using play opportunities to narrow a kid's gap in understanding about their own healthcare. My approach will usually involve equipping any play spaces with as many medical-centric toys as I can, like doctor kits or other toys, to help egg children on to learn more about their treatments and any treatments in the future. So one really rewarding thing for me in my job is that I can usually build rapport pretty quickly because my approach is rooted in play and engaging them in what they enjoy. For a lot of these kids, they connect best with people whose agenda is rooted in just promoting what's familiar to them. When they're engaging in stuff that puts them at ease, whether it's in the playroom or playing at the bedside, then they'll be willing to discuss heavy topics and open up about treatment-related things. So during play every day when I'm in the hospital with kids, they're making symbolic associations between their treatment and seemingly unrelated objects. An example might be a kiddo is playing with a race car track, and maybe they're pushing a car through a tunnel and say, hey, that looks a lot like the tunnel that I saw during my MRI. And then for this kid, making that association may lead to a larger conversation about how they're coping with treatment. Next is play reduces regression. So beyond the physical regression, kids with cancer can also show regression in social and emotional ways, such as patterns of attachments, social withdrawal from peers, and difficulty regulating emotions. So with this, kids' brains don't have the same capacity to flourish as they do under normal circumstances. But when they're consistently playing, their minds are challenged to stay on track into reaching developmental milestones. And this is especially important in children under 2. It becomes so important for staff like me within the hospital to collaborate with those parents to stay the course and hit those key milestones in those first 2 years. So play also encourages the strengthening of bonds between family members, which is maybe as important as ever when their child is diagnosed with cancer. So some common feedback that I've received over the years is that the helplessness that many parents describe when their kid is stuck in the hospital, it can be alleviated when they just simply see them act like a kid. Just seeing them engage in small bouts of playtime will give some reassurance that their child, who has had so much taken away with this experience, is still able to do many of the things that bring them joy. So any play opportunities should really prompt parents or other caregivers to engage and play with their kids as much as possible. I can only do so much as a child life specialist, and many parents that I work with, they really need that extra push to put aside their own stress and get back to the basics of engaging their kids in playtime. And of course, play should also include siblings as much as possible. So for brothers and sisters that have someone in the hospital that's a sibling that's sick, they really need to see that sibling just playing with something that they enjoy for their own coping. So kids really have an amazing ability to refocus their attention during painful episodes. Distraction using play is something that I do every day in my job when kids are going through something tough and invasive, maybe like a vaccination. And there's a really cool and impressive body of research that's a presentation in its own about virtual reality gaming and its role in reducing pain and anxiety during procedures. So for older school-age patients and teenagers, many hospitals have started to use this technology to strap kids during painful procedures. And when I've seen it, it's just really cool to see their ability to divert a kid's attention and allow them to cope successfully for a procedure that otherwise caused distress. So like I said before, emotions for kids and their parents can really, be difficult to describe in conversation. And specifically for kids, play is a safe venue to explore feelings that may be too hard for that child to articulate. Play is maybe the most familiar format for them to reveal and process any traumatic events that may be normally viewed by the child as too dangerous to talk through a normal conversation. So imaginary play can be especially powerful in providing children what we would call a transitional space that blends their free-flowing minds with the external world where the trauma occupies. And in a safe space like the playroom, kids can create scenarios with different endings that are related to the specific care that they've endured. And then they will be able to process this with a trusted professional or caregiver. So now that we've discussed the value of play and we've highlighted how it's incorporated into the hospital experience for patients with cancer, I just wanted to transition now into what can be done by school personnel specifically through play and other means to support patients and their families facing a cancer diagnosis. So I'm sure it's been touched upon already today that the best approach to supporting a student with cancer who's missing any significant time in school is an approach that uses collaboration and expertise from all relevant staff in the school and staff within the hospital coordinating with one another. And obviously the parents are going to be central to that. They're going to be ones kind of guiding the ship with help from all people involved. So the length of absence, the period of absenteeism can really vary between patient to patient pretty drastically. Some patients, most prominently those with the more common types of leukemia like ALL, will generally be out of school for at least 6 months. But there are some diagnoses like certain brain tumors that may only cause the patients to be out of school for a few weeks initially. So during this long absence, like I said, a multidisciplinary approach, like I mentioned, is the best way to ensure that the patient and family feel supported on multiple levels. Roping in any counselors, school psychologists, social workers to assist the family, and especially the sibling during that absence, while the brother and sister getting treatment will ensure their emotional well-being is also being addressed. So I hope today that everybody has learned a lot about pediatric cancer. But if you are in need of additional knowledge or support when faced with this situation, definitely don't hesitate to reach out to available staff that work in your local hospital for advice, guidance, or in-person support. So a lot of child life programs specifically do a lot of community outreach, and there's a lot of professionals that are available to help guide you and support you guys in the classroom. So these staff members work with cancer patients every day, so they'll be very well versed in how to talk to kids about cancer treatment. So when I'm talking to a class or any group of students or just group of kids in general, there's a few basic talking points that I'm always going to focus on for kids who may only have a very basic idea with what cancer is. So I always want to convey that the student didn't catch cancer. I kind of always make the analogy of like cancer is like a broken arm. You don't catch it. It doesn't get passed to one another. Another is that pediatric cancer is very rare. We always want to make kids know, especially really young kids, that you're talking about this very scary experience, and you don't want other students thinking like, oh, I'm gonna get cancer next week. I don't know the exact data on how many cases there are in the United States a year, really only a few thousand. So it is very, very rare. You always want to also convey that nothing predictable caused this. There's nothing that could be done to prevent this. And I think it's important too to convey to the class that anything and everything is being done to help the patients, and that doctors expect a cure. We don't know what the future holds, but I think good language to use is that the doctors, in the vast majority of cases, they expect a cure. So for any student that's gone, there's some simple measures and gestures to help maintain connection. I always love it when classes prepare care packages for a student that's in the hospital. Signs or cards from the class to hang in their hospital room. Or I know that there's been a lot of cases in kids I've worked with where efforts are made by the school staff to encourage small-scale attendance to school for brief periods before full-blown reentry. Maybe it's going to lunch with peers. Maybe it's attending recess or a half day. So I think that there's some different things that schools can accommodate patients with before a full-blown return. So now the programming and resources that ASK provides to patients and families and educators is amazing and really second to none. But I just wanted to do a quick shout out to 3 other organizations that also provide great and unique resources to schools with a student in the middle of treatment. And you may already know of some of these resources, and they may have actually been discussed today, but just wanted to reiterate how great they are in supporting educators. So I'm only going to briefly mention details, but if you want more info on these, there's a QR code at the bottom of the next 3 slides that will link to their website. So Monkey in My Chair is a really cute program that was established through the Love Chloe Foundation. And how it works is that the patient and the class are each provided a stuffed monkey. And in the absence of the patient with cancer in school, the monkey kind of takes their place and is taken to various locations around the school, like maybe to lunch and to the library, and then it will kind of just sit in that in that patient's desk when that patient is absent. So it's provided at no cost to families, and even contains an online component with what they call a monkey message portal, where pictures and other documents can be shared between the patient and their peers. So another great organization, which I'm sure many of you have heard of, is the Livestrong Foundation, which has been providing resources to families for decades. They have a great collection of activities and supportive content for teachers to educate their students on cancer in a developmentally appropriate way. And it's even organized into lesson plans for all grades, and is intended to empower teachers to have open and honest discussions. And then I know that most of you know about HopeCam. So it's a great resource that can assist schools in maintaining connectivity through technology. And they're great and really flexible. And they focus a lot on kind of just the social inclusion of hospitalized patients and things. And the emphasis, is a little bit on the academics, but it's really mostly on remaining socially connected. So some of you may be aware that there's a ton of great children's books about cancer. So the field of children's literature is really kind of taken off with addressing a lot of specific diagnoses and even some specific issues like hair loss. And some books will describe why patients with cancer lose their hair. So there's just 5 that are pictured here in this slide, but if you're on Amazon or Google, there are dozens that will be applicable to your classroom. So I want to talk a little bit about the experience of siblings that have a brother or sister undergoing treatment. So from the moment that their brother or sister are diagnosed, the dynamics shift dramatically within the family. So one or both parent is constantly at the hospital initially, with the siblings staying with grandparents, maybe family friends. And the messaging on what's going on always isn't great with siblings, and they lack a lot of key information those first few days. And this lack of information may cause them to create a false reality into what's happening. So once treatment is started and families get into somewhat of a routine, parents are constantly taking that sick child to appointments. And it becomes really common for a lot of complicated feelings to arise in siblings, like jealousy or maybe even guilt that their brother or sister is having to go through something so serious that they themselves don't have to endure. And so for any siblings, it's super important for any trusted adults in their lives, whether it's at school, elsewhere, to reiterate that any feelings that they're feeling are okay and normal to be experiencing. So within the school setting, ensuring that they have proper space and outlets to vocalize their worries and concerns is really important to their coping. But also for some siblings, maybe the best strategy is just kind of to let things be. Because for a lot of siblings, school can be a reprieve from all the hardship and abnormality they're experiencing. School may be one of the only stable things in their lives. And just kind of being on standby to monitor any behavioral changes is a great approach. You're going to take cues a lot of the times from parents that will allow the school to best understand what approach to take with each sibling. So also a lot of great resources for siblings that are out there, like the Leukemia Lymphoma Society. Alex's Lemonade Stand also has great specific resources on their website that are helpful in supporting siblings through their brother or sister's cancer journey. All right, so now the student undergoing treatment is a point where they're physically okay to attend school, and hopefully their reaction to returning is at all like this kid's excitement in the picture. But even with an excited student, there's a lot of nuts and bolts for the school to consider in a formalized reentry plan. So for most of these kids, returning to school can be the most significant way that they return to normalcy. A solid reentry plan should prioritize the emotional needs as much as the academic needs. So younger students, in my experience, will generally embrace some gestures to welcome them back. But I know that there's been some cases of kids that may want to treat their return as anticlimactic as possible. So just make sure you're, again, taking cues from the parents on the best approach in welcoming the student back those first 2 days. So typically developing children, young children have a really muddled sense in how illness impacts their childhood. So just even providing basic info to the class on the experience of their peer can be really beneficial. So we really want to make sure that we're communicating to other students when they return how their peer may be feeling overwhelmed or exhausted by answering so many questions. And one measure that can be taken to address any and all questions at once is an individualized back to school presentation that should hopefully be offered at most hospitals by child life specialists or other personnel. So this is a formal presentation with developmentally appropriate content that's either done shortly before return or sometime during the first week back. So child life specialists who perform these, usually hour-long presentations, they're uniquely positioned to provide an in-depth discussion on how their cancer was discovered, what happened during treatments, and why they lost their hair or experienced other symptoms. So it should be a really interactive discussion where open and honest answers are provided to help classmates better understand how cancer has specifically impacted their classmate. So speaking of being interactive, usually what I'll do and other child life specialists I've known will bring a few teaching aids to help just visualize different procedures or concepts such as hair loss. So there's only just 2 seen here. These are the most common ones that I've used to help mainly illustrate how chemotherapy is given. So the first is a chemo duck, and most large-scale hospitals should have access to both of these. So with a chemo duck, it's a tool that I often also use when conducting medical play with patients. And the Medican doll is a little bit more clinical, and it has an actual Metaport attached to it to help kids understand how chemotherapy is given. So these are just great hands-on resources that will be often brought into schools to give peers just a better conception of everything. So, and also during these presentations, typically I'll play 1 or 2 activities to provide hands-on teaching to classmates on the concept of cell growth and how normal cells turned into malignant ones. So the first one I've listed here, which I can't take credit for creating, it's done by a lot of child life specialists. It's called blood soup, and it's used to show how healthy cells got sick inside of the patient's bodies. So it specifically addresses leukemia. And really kind of how it works is that we use materials that are commonly familiar to children, usually things like candy or art supplies. I usually use candy, and what I use to symbolize the main 3 types of blood cells is for white blood cells, I use Tic Tacs. For red blood cells, I use hot tamales, and for platelets, I'll use lemon heads. So then usually you'll fill up a vat of water and dye it red to represent the blood, and then I'll have something else that represents malignant cells called blasts, and something else to represent chemo. And it's basically very interactive. Kids are throwing things in the vat of water, they're stirring it up. And within this activity, I'll provide narration to go over some teaching points about how blood cancer works. So the other one listed here is called Crazy Cells. So I developed it to help educate patients, specifically to educate peers of patients with bone cancers on what happened inside their body to develop a tumor. So how I do it is I ask everyone to gather in a semicircle, and I'll start to I'll do a semicircle to kind of mimic the shape of a bone. So let's say we have that patient developed a tumor on their tibia. So we'll kind of pretend that semicircle is the bone, it's their tibia. And I'll throw a couple bouncy balls in at first, encourage kids to throw them to one another. It's going really well. But then I'll start to introduce more and more cells that kind of also it's supposed to kind of represent the process of cancer cells growing out of control. And so I'll throw a bunch of bouncy balls in. Kids aren't able to keep up with it, and I will help relate it to what their peer has gone through with the tumor inside of their body also becoming chaotic and cells firing rapidly and growing out of control. So I just wanted to share a great case study and how impactful these presentations can be. So a couple of years ago, I worked with a patient who we'll call Samantha. So she was an 8-year-old that was diagnosed with acute lymphoblastic leukemia, and she'd done really well with treatment overall. She had spent quite a bit of time in the hospital, but generally coped well. So about a year into her treatment, she was medically cleared to return to school. But unexpectedly, she was extremely apprehensive to going back. Just even talking about it was triggering for her. She was just really worried about going back because kids would ask a lot of questions of her. She hadn't even been to 3rd grade yet that year. And she was just so worried about being bombarded with, where have you been? And why is your hair short? And other questions that would be really tough for her to answer. So this apprehension was also shared by her mom, who didn't want to be the bad guy to force her sister, or to force her daughter back into the school setting, and was fearful that Samantha would be traumatized by her extreme nervousness in going back that first day. So despite Samantha having been supported in multiple ways by a lot of different personnel, she really wasn't budging, and she was refusing to return until we introduced the concept of me coming to her school to talk to the class. And then she completely pivoted, because of the close nature of our relationship and how I've supported her over so many months. She then started to express excitement for the first time in going back. So once a return date was then set, and once the logistics of my visit were worked out with the school administration, I then worked with the family and her teacher to highlight specific things that should be addressed. And a prominent feature of this reentry plan, and any reentry plan, is to give the patient control. So we gave Samantha control on a lot of aspects, like if she wanted to be present, if she wanted her mom there, and what props to include to help educate the class about her leukemia. So I'd say that this presentation was a perfect example of how successful these talks can be for both empowering the family and the school staff. And it really kind of, brings a huge burden off of the school as these talks can be really difficult for teachers to have. And When these talks occur, teachers can then later on address any misconceptions that didn't get addressed in the moment, and they can take emotional stock in other children's relationships to not just cancer, but the experience of going to the hospital as well. So how do we incorporate both play and learning to support the whole class of a young child who is undergoing cancer treatment? So I think it's easy for a lot of us to forget that play and learning are inextricably linked during early childhood. Classrooms that base their curriculum on an understanding of this will have learners that thrive both academically and socially. And there's no better opportunity to implement this philosophy than when a child with something like cancer is returning to school. The stability of the school environment is the perfect place for any child to learn. And as many of you can attest personally from your experience of teaching during the pandemic, virtual learning just doesn't cut it and provide the same hands-on opportunities for academic and social growth. So when kids with cancer are learning in person, teachers have the capability to assist them in scaffolding and other skills, either during formal learning modules or during more free-flowing, purposeful play sessions where play is embedded into the curriculum. So unfortunately, trends in education, as probably many of you know, have led to a drop in teachers promoting purposeful play and free play over the past 30 years. And at the turn of the 20th century, schools became a lot more focused on rigorous, skills-based curriculum that neglected play as a means to learning in schools. Experts cite the No Child Left Behind Act of 2001 as a real turning point with this, with kids moving away from play opportunities. So this movement away from play also coincided with greater expectations for kids entering grade school. Now, even kindergartners in districts around the country are expected to possess a greater degree of introduction of phonics than ever before, and then play will go on the back burner. So also with this, technology and its pervasiveness in education has made it much more difficult for many teachers to get back to basics and using traditional play as a tool to learning. A middle ground between formal learning that is curriculum-based and lessons guided by purposeful play can create an ideal learning environment. So I just kind of want to highlight some ways that you guys can normalize medical care in the classroom. And I utilize these 3 activities pretty consistently in my therapeutic activities that I'll engage in with patients. So some of you guys have probably heard of the concept of loose parts, that it can really be utilized anywhere with young children. So for those of you that aren't familiar with this style of play, it's basically just providing a variety of different unrelated materials with no preset rules on what to design with those materials. Really only simple prompts are provided by an educator to follow a theme. So themes that I'll employ, obviously have to do with some component of the hospital. So it can be a great STEM-based play activity to challenge kids to think about healthcare concepts like anatomy, body processes, and medical equipment. So secondly, teddy bear clinics are conducted by nearly every child life department in hospitals around the country. So patients will use their own stuffed animal or teddy bear and are provided one by staff. And you kind of go around to different stations that emulate the hospital of experience. So there's a station set up to give your teddy bear an IV, one to admit your teddy bear to the hospital, one to go to surgery, one to get an MRI. So it's a child-directed, yet we provide basic teaching about the hospital. Child-directed type of play, but we're providing basic teaching about the hospital as well. So this can be easily adapted to fit a classroom setting. In any structured play, maybe any structured play you're engaging in can be something as simple as going to the doctor or helping your bear with an injury. And finally, calm down kits, which maybe many of you have utilized in your classroom. So they're just a mechanism to help kids cope in the hospital. So kids are designing these calm down kits with different items that they're to utilize when they get angry, sad, stressed. So things like a pinwheel, bubbles, stress ball, or other sensory items that are used to help kids cope in a given situation. So I urge any educators tuning in today to utilize games like this or activities just to provide basic education on the human body, childhood illness, and how to just cope in general with stressful events. Notably dealing with going to the doctor or hospital. So in addition, there's some common games that I play consistently with kids in the hospital that can also be tailored to the classroom setting. So hospital-based bingo is utilized often in child life departments around the country. So there's plenty of templates that can be printed online. So if there's any classrooms that play bingo out there, it can be you can pivot to doing a hospital theme one. It's really fun to do, and it'll just kind of spur a conversation about going to the hospital and being sick, and may even be used to address a classmate's return after cancer treatment. So all kids love scavenger hunts. They're always fun to do. So a hospital-based scavenger hunt where different pictures are printed and then hit around the classroom that have to do with the hospital or going to the doctor will be another great way, fun way for a conversation to be started. And a lot of times I'll kind of retrofit a board game. So an example here is memory. So every kid has played memory before. So a lot of times I will make a hospital themed memory that will then be used, played and then used to just kind of spur a conversation about, oh, this is a mask that, we all wore during COVID, but we also wear in the hospital. Oh, this is a stethoscope. I saw that when I went to the doctor. I saw that when I went to the hospital. And we'll just get kids talking about going to the hospital, and we'll help normalize their own healthcare. So, and finally, just some take-home points today to remember as you all leave this, hoping to help support any child or sibling impacted by pediatric cancer. We want you guys to utilize resources, both local and national, that exist to educate children on pediatric cancer. We want you to rely on support from school personnel to manage the absence within your school and classroom. Use both free play and purposeful activity to promote the understanding of medicine. We want you to incorporate activities that promote healthy coping and help children become cognizant of their support structures in place. And lastly, advocating for curriculum that further educates on the hospital experience. I just wanted to end on a quote today from the awesome Fred Rogers, who also in his day did a lot of great work on his show in educating kids on illness and going to the hospital. So he says, play is often talked about as if it were a relief from serious learning, but for children, play is serious learning. Play is really the work of childhood. And then one more thing, on the bottom of this slide, I've included a QR code at the bottom right that will link to a website from Ask. It's their educational toolkit, which has a ton of great resources for educators to make the back to school transition successful. So it's there for any of you that haven't linked to it yet.
Thanks, Joe. That was such a great wealth of information, and you really painted a picture of what it's like for children when they're in the hospital and clinic and going through treatment from more of the hands-on, not just the medical side. We have a couple questions. The first is, what's the best kind of play in school and at home to help with trauma healing?
I would say play that, is a combination of being both individualized and in group settings. So I hope that every educator or school staff tuning in today has great resources out there and great personnel working in the school. So school psychologists or somebody else that has a background in play therapy, I think would be especially helpful. So I mentioned it at the very beginning of my talk. So play therapy is incredible. It's a separate discipline from what I do. And there's a lot of psychotherapists or other counselors that have a background in it. So I would advocate as best you can to get somebody with a play therapy background that works at your school. But educators in general that are having these purposeful play sessions or free play sessions, just ask some of the kind of the prompting questions. I think like some of the ones that I outlined that I use to get kids talking about trauma or being in the hospital, just kind of asking very broad general questions in a non-threatening way, I think is a great way to get kids to open up about the hospital and their experience in their cancer journey.
And then one last question. Teens can be very open to child stuff, but how does Child Life approach them since they are really young adults or on their way to being young adults?
Yeah, so unfortunately, I wanted to include a lot about teenagers in this presentation, but I tended to focus more on younger kids, younger school age kids. the approach with teens is very different, obviously, from how you're going to approach things with younger kids. How I support teens is I tend to kind of more talk to them, obviously, as kind of I would talk to a young adult, because I think that a lot of teens that are in the hospital for cancer or they can feel infantilized and they can feel like so much autonomy has been taken away. And talk about regression, I think it's so evident for teenagers because they're in this children's hospital, which children's hospitals, they're designed mostly to help younger kids heal, and there's not a lot of spaces and resources for teenagers. So I think the hospitals are getting better with that, but I think to support teenagers, just advocating for those developmentally appropriate tools and resources to help them cope, whether it's video games, more psychologists that work in the hospital to help them cope. There can be a variety of different things to help improve the well-being of teens as well.
We are out of time. Joe, thank you so much. Great presentation. We really appreciate it.
Thank you so much, Susan. So happy to be here today. Thank you, everyone.
So we are going to take a break, about a 15-minute break, and we will be back at 2:15. Welcome back, everybody. I am very excited to welcome our panel of childhood cancer survivors who are now young adults. They will share their experiences transitioning back to school after treatment, challenges they faced, and what helped them the most. So we'll start by doing introductions. I will have you guys introduce yourselves. If you can share your diagnosis, age at diagnosis, any relapses that you may have had, how old you are today, and then what's going on in your life today with you. So we will start with Juanita.
Hello, thank you for having me here. I had acute lymphoblastic leukemia. My name's Juanita Prada. I had acute lymphoblastic leukemia at the age of 10, and then I relapsed at the age of 13. Yeah, and I graduated from Virginia Tech much year later in my life, but it's a proud moment. And now I advocate for the late effects of childhood cancer, and I'm very involved with Behold Behold.
Which you started, right?
Which I started. I'm founder of Behold Behold. Yes.
Important point there. I feel like we should highlight.
Yes, very important point.
Erin, can you introduce yourself, please?
Hi, my name is Aaron Redmond. I was actually diagnosed in 1994. So I was in fifth grade and I started treatments on my 13th birthday. So that was kind of not a very pleasant moment to spend a birthday at 13. I mean, excuse me, at 12. So I went through a year and a half of treatment at VCU MCV at the time. And then I graduated from Virginia Tech in 2006 with a degree in political science and history. And currently, right now, this month will be next month, March, will be my 29th year out of treatments. No relapses or anything like that. So hopefully nothing like that ever happens again. And currently, right now, I'm a project manager with Dominion Energy. So thank you all for having me. I appreciate it.
Thanks, Aaron. Hallie?
Hi, everybody. My name is Hallie Spencer. Thanks for having me. I was diagnosed with Hodgkin's lymphoma at the age of 14. This was back in 2008. No relapses, thank God. Once I got through treatment, chemo, radiation, nothing ever came back. Currently, I'm 30 years old now. I have a beautiful 4-year-old. I went to Virginia State University and I graduated in 2021 with my criminal justice degree. And I actually just landed a career in probation and parole.
Congratulations.
Thank you.
Nora?
Hello. Wait.
Yep, you're good.
I'm good. Hello. Thanks for having me. I'm Nora. No relapses. I'm 24 years old. My cancer treatment was histiocytosis.
And what kind of cancer is that? And
It's a brain tumor.
Okay. And how old were you when you were diagnosed?
12.
Okay. And what are you doing today?
I work at Publix I recently moved with my family to Ocean Isle, North Carolina, and I transferred at Publix, so I work for Publix in North Carolina.
That's great. You were able to transfer and stay with the company. And last but not least, Ishan.
Hello, everyone. Thank you for having me on this panel. My name is Ishan Vishwakarma. I was diagnosed with neuroblastoma stage 3 at 4 years old, and I have not had remissions, and I have not had any reoccurrences of cancer, and I've been past remission and healthy, and today I am a sophomore at Harvard College studying statistics and economics. And yeah.
Great, thank you. So the first question I'm going to address to Aaron and Hallie, and it is, what have been the most difficult parts of your childhood cancer experience? Well, why don't we start with Aaron?
Okay. So when I was diagnosed, like I said, I was in fifth grade. I was diagnosed with a cancer called orbital rhabdomyosarcoma. So a little brief background, it won't take long, but how I was diagnosed is I was at school and I came home and it looked like somebody had punched me in the face. The right side of my eye was swelled and pretty much closed out. So anyways, my mom threw a fit and had me go to the doctor because I told her we were just got in a pencil fight at school or something like that. So we went to the doctor, and then that's how I was found out. So being an active, 11, 12-year-old playing sports, your life's pretty much upended at diagnosis. I was pulled out of school because of risk of infection from treatments. So I was in isolation pretty much the remainder of my fifth grade year and pretty much the start of sixth grade year. I was pulled out of sports because I had a portacath. So the biggest challenge that I found at that time was, you have friends, they go on with their life. Luckily, I had baseball friends that kept in touch with, but you're isolated from your routine. You lose that sense of childhood, that normalcy. Luckily, my parents were great and kept me intertwined, and had friends and family that were allowed to come over and meet from a distance. But you're just not allowed to do the normal things as a teenager. And I feel like that was the most difficult challenge that I found. The other challenge is it forces you to grow up really fast. In 1994, there weren't a lot of survivors at that time. So the difficulty is you have a lot of survivor's guilt. You lose your friends that you grew up with through treatments, and to see them, and you're like, well, why me? Why did I survive and they didn't? As time goes on, as I've been able to give back, I realized, it to me it was a learning curve. It made me grow up faster, but I'm very grateful for the experience that I went through. So,
Thanks for sharing. Hallie?
I would say some of the most difficult parts of the illness is the immediate change you go through, like your mind and your body, and everything just changes, in the blink of an eye. And you have to, try to prepare yourself to, well, what's about to happen, because you don't know. Being in school, though, I would say bullying was like the worst aspect of it all, because of course, yeah, kids are going to be kids. They don't understand maybe what you're going through, because honestly, you don't really understand 100% yourself. I know I didn't, speaking, for me. And I think what hurt, some of the things that hurt the worst was, being in a school setting and like administrative, physically seeing people, picking on you and things of that nature. And they never even like stood up or said anything. So it was like a feeling of not feeling protected, because now I don't know, like I don't have that protection there. And I always use the term, you guys heard of the term, sticks and stones may break my bones, but words will never hurt me. But those words stung. And I will say, being, becoming a woman, and because it, like piggying back with Erin say, like it pushes you to grow up faster, and it those things stick with you, but as you get older, you learn to, heal from that. But being younger, it was hard. It was very hard, I will say. Yeah.
I see Juanita nodding. Do you feel like you were bullied too, Juanita?
Yeah, I mean, all these things that obviously we're gonna be talking about. It's like you can put yourself on everybody's shoes. I'm thinking, I remember just getting bullied by going back to school just for a day, and then obviously I had no hair, and then this guy coming, and they're school age kids, and they just come and they take off my hat and they put it in the floor, and I'm just like, obviously I'm laughing now, but it's not funny, of course. It's really sad. It was really traumatizing. To this day I remember it. And the same, I had it as a, my experience is unique because I had it as a child and as an adolescent. So again, the hair fell out again, and the kids, looking at you, the steroid fate. So yeah, I can relate a lot to the bullying.
What educational challenges have you experienced due to late effects? And I'm gonna direct this, actually, Juanita, to you.
Oh, to me. Oh, okay. Yes. Cognitive. We're talking about school. So yeah, I had a lot of cognitive difficulties. Primarily, I was in a coma that led to a stroke for a year, meaning, there was a lot of damage in my brain. And it was, something that I always go on about and share my story that thankfully I'm a very social person and everything, but it really damaged a part of my brain where a lot of the mathematics and a lot of the sciences just didn't go with me because it was a lot of memorization and step-by-step stuff. So the cognitive really was a thing that affected me a lot. And today I live with seizures from the past stuff that happened to me. So, it is still something that at 31 years old, I deal with. I had to unfortunately leave the work environment that I was in because of my health, because I needed to prioritize my health today. So yeah, it's something that stick through the memorization, the repetition, every class, I had to take a class, a semester, another semester, just to be able, summer school, every summer school. There was no after school. There was no recreation. There was no other life as I knew it, but try to memorize and get through the class. That was really, I would always emphasize. And then fatigue was another thing that, we're thinking more aspects of the physical health of a child, right? Just skipping a lot of school and because of the fatigue part and how that affected also just physically. And I could go on and on about it, but I know I have my time still.
Yes. Were you able to stay on grade level and progress with your peers?
Yes, fortunately I was, because there was no summer. It was always summer school. There was always coming in before school, and there was staying after school till 5 o'clock. There was no life. I emphasize there was no life. It was just getting it done, take your breaks, go back and study, and go back and study, and go back to study until, that was engraved for a day. Literally. And just pass the exam and get through it, kind of thing. Yeah. So a lot of, I look back at it and it's like, wow, it's crazy. But I finished up at Tech studying human development, and it got me, I didn't care how many years it took me to get to higher grade education, but I speak about it today. I'm very proud of it. I ended up going to community college, which helped so much. And then I transferred to Virginia Tech, and always advocating, just that I need the help,
What a phenomenal accomplishment when you consider what it took to graduate from Virginia Tech. You should be very proud.
Very proud.
Ishan, what educational challenges have you experienced due to late effects?
Yeah, so going off of many of the challenges which Juanita mentioned, there were primarily two categories of challenges which I experienced. A lot of cognitive challenges, so with quantitative tasks like quick maths and certain worksheets, I wasn't able to perform at the level of my peers. And being diagnosed and treated at a very young age, there was a lot of confusion as to why I wasn't able to match up with my peers. My teachers didn't understand, and frankly, I didn't understand either. It felt very frustrating and felt like I was always a step behind my peers. So it, like Juanita mentioned, it took a lot of energy, especially in elementary school. There were risks of me being held back, and it took a lot of extra work to match up to my peers. And even in middle school, there was always a moment where I wanted to excel further. I wanted to get into gifted programs. I wanted to match up to what the other students were doing in my year, and it just wasn't possible due to these underlying challenges, which would only be realized later on as more research came out on the specific chemotherapies which I received and how they altered a little bit of my brain function in those quick quantitative tasks. But I mean, as I say today, being a student at Harvard and studying statistics, which is a quantitative, right now I'm taking linear algebra. Last semester I took multivariable calculus. Like these are very difficult classes, and really it shows the strength of these cancer diagnoses and the treatments that we receive. They alter certain parts of our mind, but it doesn't make us we're still able to do very complex tasks, and that's what I found. While teachers had a lot of doubt in what I was able to do, I found that through a lot of persistence and hard work, these challenges have been surpassed, and I found my strengths and weaknesses, and I can play to my strengths being in this university right now.
Did you have a 504 that followed you to college?
Yes, so that was another key thing. I had a 504 plan, which was um, it was set up through the help of Ask and Miss Elma Morgan at Ask, and she was a strong advocate for my health going into middle school and high school. And in high school, it reminds me I had 2 additional surgeries, which the correlation isn't clear whether it was connected to the cancer or not, but those were educational challenges which put me out of high school right before COVID. So I was missing a lot of my high school, and those 504 plans really aided in that. And those 504 plans continue in Harvard, where I get extended time to work through those mental math situations. But um, really, it's all about just leveling the playing field. And I think uh, that's what I'm really glad that Harvard provides those resources, and 504 plans really helped level the playing field so I could perform with my peers at the level that I truly believed I could.
This question is going to be for Nora and Juanita. What types of support did you receive from your school? And is there anyone, teacher, counselor, anyone at school who stands out in your memory? So Nora, we'll start with you.
Doris, because I did Wilson Workforce Rehab Center in Fishersville, Virginia. It's like an independent, it's like in college, but like be more independent. And I did like all the vocational training, and then I did like materials handling and like trying to work in a grocery store. And then I did also, there's other programs like driving, learner's permit.
That's great. I mean, I've heard wonderful things about Wilson Workforce Center.
Yeah, they're all great.
And getting a driver's license is a really big deal for a lot of survivors, and because it allows independence and able to get to work. So
yes,
that's great. Juanita, what types of support did you receive from your school? And is there anyone a teacher or a counselor, anyone like that kind of sticks out in your memory?
Yes, and yes. So I received both an IEP and 5-year-old plan. Focusing on accommodating really all the needs that I needed due to all the cognitive stuff that was, that I underwent, that I'm still undergo. But the point is there that I had all this support that was happening, if I would go, again, I had to concentrate very well because it was just a matter of getting all the information in my head. And again, taking that pop quiz or that exam or something that's coming up and trying to memorize. So going to a separate space, I recall that support from teachers, and just they'll take me out and do this. I do have to say, it's a little, when you're a child and then you get cancer and automatically you come back to school and then everything changes from like before, meaning you were in the same class with your friends and then you had cancer and then you go all this and then you're gonna put me back into the school system, and then suddenly they're like, no, you're not back with your friends, you're in this small classroom with 5 kids, and then you're just like, why? And anyway, so all that, that just had to get that out because it's a point that I want to make to teachers to also be attentive of the emotions these children go through rapidly and drastically, and yeah, so I had that type of support that really helped a lot. Teachers reading to me, having that space, hearing it, text wise, everything. And then also the teacher that stands out for me the most is Jessica Ficaro from Case Spring. Case Spring High School, Case Spring Middle School. Now I think she's in Penn Forest. I think, I don't know. But the point is that this lady is amazing. My dad, we're Hispanic, but the point of that is that, you know, she was very, very culturally sensitive as well. You know, and my dad has a personality that, you know, is, of course, it's their baby and everything, but she really understood my dad and that my dad was worried about my educational needs and this and that. And she was the lady who would come in here in the morning. We're going to repeat these math practices. And this is what you're going to see in the class. And then after school, we're going to go over it again, Juanita. You're going to pass this class. You're going to pass it. Do all those kids go through this? No. Like oh my gosh, she motivated me. And I felt every time out of that class that I was going to jump out that window and rock it. You know, I'll be like, yes, I'm ready for tomorrow. And that's really what I saw in my life. I had a motivator, a teacher. I was very blessed, you know, and she was with me through middle school, high school. And then later on, she sent me to phenomenal services for adulthood. So very appreciative of her. She just rocked it all the time, not just with helping me with school, but also helping me emotionally, you know, and not feeling bad for me, treating me like everybody else, you know. That's what I really admired and love about her. She's great.
It really speaks to that one person, the one teacher, the one trusted adult who can make a huge difference.
Yes. And I want to note there also that she was very flexible. You have a headache right now, go to the nurse. Juanita, no, go to the nurse right now. But I'm going to miss the class, Miss Vaquero. I don't care. Your health comes first. So love it. People like that, teachers like that, have an A in my heart. Cheesy, but yeah.
This next question will be directed to Hallie and Ishan. Is there an educational support that looking back would have been helpful that you didn't receive? So we'll start with Hallie.
I will say I wish that, you know, I don't know if Ask was around then or not, but I really wish that I had that type of support then, like that I actually knew, because I tried to do homeschooling at one point, and it was no help, you know. When I actually went back into physical school, you had some instructors who just felt bad for you overall and will kind of just push you through, but you don't learn that way, you know. And then you had some educators who, all right, well, you're physically here, there's nothing wrong with you. I'm not going to work with you one-on-one. I have other kids to worry about. So it was kind of like, almost in a sense, other than maybe a few instructors, a lot of it was, I feel like, failed in a sense, you know, because here I am, I'm applying to colleges. I finally get into college, and my first day going into classes, I don't know none of this. Like I'm lost, you know, and I'm like, well, who do I turn to? You know, I don't know if like my mom knew about like outside services or anything, but like I struggled hard, you know, and it didn't take until finally I came back. I went to Richard Bland. I came back. I went to J. Sargent Reynolds Community College. And I believe I actually reached out to Miss Alma Morgan. And I said, I'm struggling over here. I need some help, and I don't know what's going on. And as soon as I said that, you know, she sent over a plan for me. She got me those, you know, right accommodations that I needed so that I could succeed, because it was as if the school system, I hate to say it, but it failed me because I wasn't prepared. I wasn't prepared. Here I am going through an illness, and I'm thinking like, okay, well, yeah, I'm done now. I'm in remission. I'm normal again, you know, but you're never really normal again in that sense. You know, you have to work really, really, really hard, you know, and you always face those challenges. But the fact that like I didn't have anyone in my court to kind of advocate for me, you know, because I didn't understand. I was still a child myself, you know. It was challenging, you know, and I just really wish it was just more support then, you know. So.
I have heard parents describe parents who are not familiar with like accommodations and educational plans describe it as a game that you don't know the rules to. And it sounds like that's kind of what happened for you, is that your mom
Yes.
probably didn't know the rules to the game and how
Yeah.
to ask for accommodations. And
Absolutely. Absolutely. I'm just so glad, throughout times things have changed and more things are open, for people to, be aware of and get the help that they need. The fight continues.
right? That's why we're here to
Yes.
educate.
Absolutely.
Ishan, looking back, are there educational supports that would have been helpful for you that you didn't receive?
Yeah, so really echoing what Hallie said about Ask being kind of a light in this really dark and difficult void of education. It was quite complex. I mean, anytime I mean the education system by itself is complex. I understand. And then you add this extra layer of having to go to treatment and having to leave school for months and years. I mean, in my case, my treatment lasted multiple years, and I was in New York for a part of it. I was in Richmond for a part of it, and obviously that shifts like everything. Everything shifted, and early on, the echoing what Hallie said, like early on, there wasn't really the resources to cater one-on-one education for a student going through these illnesses. There wasn't really that tailoring, and I mean it's just a fact of the way that a lot of these schools are limited resources, and it's sometimes very difficult to accommodate for students who are going through these really difficult life challenges. And so early on during elementary school, a lot of that burden fell onto my parents and onto um, the hospital which I treated at, Memorial Sloan Kettering Cancer Center in New York. Thankfully, they had an educational program within that hospital, but not every hospital has that, and not every family is lucky enough to um, get that support that they need at the right time. So my family got very lucky. We were able to have educational support that we found outside of school, but in school, there was quite a lot of systems which were lacking for students who go through situations like this, because it is rare. These cancers, these illnesses, they are quite rare, and it's very hard to convince school systems to invest and spend time with these students because it's once in a blue moon that they encounter these situations. And later on in high school, to briefly summarize my experience, I had multiple surgeries in high school, which the educational support, I was in a specialty center in Richmond, Virginia called the IB program. And even with a specialty center, we had a class of 50. It was more tailored. There were many more resources. But even then, I was being treated in Pennsylvania. It was a similar situation, but the educational support still fell through. And at this point, Morgan and the ASK team really was able to back me up. While I didn't know about ASK during my childhood cancer, they were really able to back me up during my high school treatments and surgeries. But it really goes to show that there's a lot to be yearned for. There's a lot of development which can happen, and uh, there was a lot of tailoring which could have really benefited my condition and really made me less stressed while I was undergoing these really difficult and really painful treatments. So yeah.
Well, I think thank you all for being here and sharing your stories, because our hope is, and that we will educate more teachers and school personnel that, the more supports are needed, and what the experience really is like, that's not seen at school, all the things that have happened before you got back to school. Our next question I'm going to direct to Hallie, Ishan, and Juanita. What piece of advice would you give young patients and survivors when navigating the school system? So we'll start with Hallie.
I'm going to say never be afraid to, ask a lot of questions and, inquire about anything. Like, utilize all the tools you can, whether it's ask, whether it's, in school services, out of school services, like, um, being, I know you can't maybe when you're super, super young, but, stepping into like middle school and high school, you kind of got to be that advocate for yourself, because we do, when I say this illness, it does like it grows you up a little bit quicker, because you're going through problems that people older than you wouldn't even imagine sometimes. So you have to become that advocate, for yourself. Utilize all the tools that, comes. Just ask questions because you never know what's out there. So the way times have advanced so much from, back when some of us were sick, a long time ago and versus now, it's so like technology and so much has grown. So you have to be that pushing force, let your voice be heard. Like at the end of the day, we are all blessings. Like we are truly blessed to have made it, here this far. So we have to be the biggest advocates for ourselves within the educational system and just within everything, just to keep on moving. And times are going to constantly evolve and things are going to constantly change. And I do believe things will become even more, better, just smooth. But we have to still be those advocates for ourselves.
Thanks, Helen.
Keep pushing. Keep pushing, you guys.
Ishan, what piece of advice would you give young patients and survivors?
Yeah, so in my educational journey, there has been quite a lot of adversities, and there have been moments where there have been weeks where I've just needed an external helping hand, and that's where Ask came in from, like during middle school and during high school, during those weeks or sometimes months where times were especially difficult, whether it was final season or whether it was a big project that was due at the end of the week. That's where a community and a circle of people who could support and uplift me, that's when it was essential. And I think the number one piece of advice is finding that circle of people who you trust, who will advocate for you and who will support you every step of the way and who understand where you're coming from. Because very often, I mean, I changed schools from elementary, middle, high school, and very often this is a common experience. And you, even with every grade, you shuffle around with teachers, and really you need to advocate for yourself every single year. And in college, it's the same. I need to advocate for myself every single semester. And it's really important that the teaching staff, wherever school you are in, they understand where you're coming from, and they also understand that you're determined and driven to excel, because they can't turn down an individual who's truly determined to excel, regardless of how it might look, like regardless of where they are currently. If they see that you're determined to excel, and if they understand your story, then and if you keep on advocating for yourself, they will never be able to turn you down. And that's what I've found. In high school, my program coordinator was trying to remove me from the specialty program I dedicated 2 years to, and I'd worked so hard to keep up in. And really, the way I was able to remain in that program was demonstrating my desire to excel and my drive, and really showing that this is a story that is part of my identity. My cancer journey is part of my identity, and it shaped my drive and it shaped my my persistence. And I think that really shows up in the educational system. So really key thing is just to advocate for yourself, have that circle, and really use this journey and use your survivorship and as a core part of your identity, because it will push you further, and it will show others how driven you are.
Thanks. I see a theme here with self-advocacy. Juanita, what piece of advice would you give young patients and survivors?
Yeah, surprise, self-advocacy. No, I mean, I'm totally on board with this train with Hallie and Aisha. That, it really, I mean, it really is about self-advocacy, learning. I learned at a young age in elementary school, then going into, middle school and then high school, that just by asking, and just by, it doesn't hurt to ask, right? And you don't know what's going to come out about the situation. That's been my rule in life, really, just going on and asking, hey, is that really on sale, or can we lower this price? Look at that button, it's ripped off. Can I, so it never hurts to ask, right? So really just asking, advocating for yourself, in the sense of, are there, going on to college? Is there accommodations in college? Really, your parents are speaking for you as kids, but then you start to grow as a teen, and again, you need to keep going on. That worked for me in elementary. Does it work for me in middle school? Is it going to work for me in high school, right? So really learning to speak up. I noticed that pattern, and it really is, I wrote on here on my notes, exactly, speaking up, advocating for yourself, advocating in the workplace. When I got into, the jobs that I've been in, also I said, look, I need this type of accommodations. Is this okay? They were like, yes, that's fine, this and that. So it's all good, and focusing on you. I think that's key, focusing on you. In school, I really started, again, thinking like, why can I be like my peers and do like my peers, and look, they're graduating, look, they're leaving, and I'm still here, and this is that, and I have to go to community college and this and that. But then again, I have those voices of the, I guess, educators, of course, who have been within my life, and that kept reminding me like, hey, focus on you. Did they go through childhood cancer? Did they have to have all those chemotherapies injected in them? Did they have to did they have the stroke? Were they in coma for a month? No, like, you're a rock star, Juanita. You got it. Focus on you. And I think, again, all about the motivation and being the optimistic like person, I guess, that I am, but just it worked for me. It worked for me. Speaking up, like all that energy, it just kept flowing and going. And that's how I live my life today. It doesn't hurt to ask, and focus up. Yeah, advocate for yourself. That's really where I stand with these awesome individuals as well.
Thank you. We have a question in the chat, and Erin, I'm gonna start with you with this one. Was there a point where the chemo brain effect got noticeably better for you?
Oh, sorry. I would have to say after college, I know that's really like when I think what it was is you don't have that support. When you go to college, you kind of lose that foundation you have because you're going to a pretty much a town and you're on your own. You're one of those citizens in that community. I like to say you're a number. You're not an individual. You're a number in college. The professors have so many kids, and a lot of it is trial and error, memorization. You have to kind of adapt to the deficiencies that you have, and you learn from that. And I would say college was one of those ones that chemo brain kind of I overcame it. I feel like, so I feel like the nuances of going through the struggle of college, the tests, the reading. In college, you do have your IEPs, your 504s, but a lot of times those professors have hundreds and hundreds of students. So you have to really do your best what you can do. And I feel like that was one of the struggles that I overcame.
So do you feel like you learned to deal with the chemo brain, or it is less than it used to be?
I feel like I dealt with it. Like I said, you learn how to overcome the deficiencies that you have. It's like retraining your brain how to think. And so that was what I was able to do. Was I able to memorize everything? No. But was I able to memorize most of the stuff that I needed? Yes. And there were certain things where I had to retrain my brain on, all right, the critical thinking aspect, the memorization. I'm a visual person. I'm not a person who can read and retain things. So a lot of things I had to write down on notes, draw charts. So that was one of the ways how I overcame it.
Thanks. Any last questions from our participants? Type it in the chat now. We have a couple minutes before we get to our very last question. So I want to read to you guys some of the comments in the chat because they're so lovely. Congratulations to each of you. You had to lose so much due to treatment and then had to work so much harder when you went back to school. You lost so much of your childhood experiences. It was really painful and hard, but you surmounted. Congratulations to you all. Totally agree about advocating for yourself, something to begin learning at even the middle school level. Proud of each of you for sharing your stories. Excellent advice, everyone. Thank you so much. So just really lovely comments.
Thank you, guys. That was beautiful.
They're still coming in too.
Bring it on, bring it on.
You're an inspiration.
This is almost like emotional.
So our last question that I'll go around and ask each of you is, what is one good thing that has come out of your cancer experience? And Hallie, we'll start with you.
So I chose a word for mine, and I'm gonna say brave. With this disease, you learn to weather the storm. And you become unstoppable at the end of the day. And you're going to face many challenges throughout life, but it's nothing that's going to stop you, It's nothing that's going to stop you. Like, you're here for a reason, and this journey has been one heck of a roller coaster, but you're unstoppable. And that's how I got to end that.
That's beautiful. Thank you. Nora, what is one good thing that has come out of your cancer experience?
Well, my word would be courage, because even though we went through like the cancer and brave and all that, courage, because we all went through the same thing and had courage to get where we are now.
That's beautiful too. Thank you, Nora. Ishan, what is one good thing that has come out of your cancer experience?
I think it would be persistence. The journey really gave me a lot of drive and persistence, and it has I accredit a lot of that journey to getting me to the place I am right now and being able to study at this university and like being able to accomplish so much is because I had to get out of a really, really difficult situation, and my family had to get out of a really, really difficult situation. And together, they share stories of how they were able to move to New York for my treatment, and all the changes that they had to make, and how persistent I was, even being so young. So I think that's been instilled in me from a young age, and that I carry that trait throughout life, and it's a very valuable trait to learn.
Thanks, Ishan. Juanita, what is one good thing that has come out of your cancer experience?
Yeah, it's encompassing a lot of the things that everybody's saying, but be whole, be gold. And people can do more research about be whole, be gold, but it encompasses that, be whole, be gold is to perceive an unstoppable force of positivity, ambition, and resiliency that arises within you, meaning out of all these survivors, while undergoing the late effects and challenges that come with surviving childhood cancer. And it really spoke to me as something that I felt the moment that I was diagnosed with epilepsy. So years later down the road, and it changed my life dramatically. So but I'm here. I am very optimistic in the sense of, for a purpose, this happened and this movement came out of it. So so we're all leaving, in positive note here. So, but yes, that's the word, be whole, be gold.
Thanks, Juanita. And Aaron, what is one good thing that has come out of your cancer experience?
To me, it's been a very humbling experience. It has made me the person I am today. One question that people always ask me is if I could relive my life and change my life again, would I change the path that my life went down? And my answer kind of baffles people. My answer is no. I feel like if I wouldn't have had cancer, I don't know if I'd be the person I am today. Um, I have to hear my nephews, they're young kids. They're like, "Oh, I want to be grown." I'm like, "No, you don't." And enjoy your life. Take time. When that blue sky's out, look up. Be thankful for what you have because there are people that didn't get that opportunity to make it past it. So I give back. One of my things is I help volunteer with ASK through the young adults or the young children when they're camping. So if I could be an inspiration for them, that's my goal in life is to help these kids get through an obstacle that they got to overcome. So I would say my cancer experience has been very humbling and has made me the person I am today.
Thanks, Aaron. Really a heartfelt thank you to each of you for sharing your experiences with us. Your perspectives are so invaluable to school personnel across Virginia and beyond. We have someone from Australia watching. I think we have somebody from New Zealand. So really the impact of you sharing today goes far beyond Virginia. And to be able to better support patients and survivors in schools across Virginia and the world. So thank you again to all of you. We will be on break until 3:15.
Thank you, Susan.
And you're welcome. And when we come back, we'll go through 2 case studies and then we will wrap up for the day. Welcome back. We will wrap up the day by walking through 2 case studies. The first case study, focusing on a child in active treatment, is presented by John Longenecker, Ask Education Support Navigator at Children's Hospital of Richmond at VCU. John has 30 years of experience as a special education teacher. In addition, he designed and developed a community program for adults with disabilities to provide opportunities for socialization. Welcome, John.
Thank you. First of all, my name is John Longenecker. I'm the Education Support Navigator at VCU, Children's Hospital of Richmond. I would like to say I feel a little bit of pressure after following those young adults. They were absolutely amazing, and as I will say, I've met some of them in real life, and as impressive as they were this afternoon, if you meet them in real life, they're even more impressive. So I just wanted to thank them for that. It's hard to follow that, but I'm going to try. Going to make this short and sweet. But I'm just going to spend a few minutes with you to just discuss a case study of a young man that I've been working with for the past few months. And again, I promise this is going to be quick and kind of to the point. So meet Jericho. He's 10 years old. He's in 4th grade. He was diagnosed with a brain tumor last year. But I'm going to let Mom tell you a little bit about him and what took place prior to.
Hi, I'm Margaret Wright, the mom of Jericho, who is a 10-year-old boy who was diagnosed this past February of 2023 with pilocytic astrocytoma, which is the brain tumor, and it was in his posterior fossa. Prior to being diagnosed with the brain tumor, we had been struggling for a couple of years with figuring out why he was failure to thrive. He wasn't gaining weight, growing. He would vomit when he ate. It was a big struggle. We were working with GI, trying to figure out what was going on. So he had been failure to thrive, which, as we know, isn't good for cognitive development anyway. But regardless of that, he is still a very funny, bright kid. When we finally got diagnosed, he was immediately scheduled for brain surgery in February of last year, 2023. And of course, the posterior fossa is the part of the brain where you have language development and just a bunch of things that go into just cognitive processing and things like that. So post-surgery last year, he had he was doing a lot of word finding, and he had a lot of memory issues. We of course, were doing PT, OT, and speech. Within a few months, he was back to what I would consider normal. We started in chemotherapy this past summer, and he'll be on chemo through the summer of 2024. So he is on, right now he's currently on rounds of maintenance. And so starting into the school year, I coordinated with John through Ask, who's the education support who at VCU on the HEMOC floor, and he was really helpful in helping me advocate in Jericho's 504 meeting. He attended that virtually, which was super helpful because there were things I did not know we needed to advocate for, as far as, number one, he's going to chemotherapy weekly, so he's going to be missing a lot of school. He's also, even though he had grown leaps and bounds since surgery, he was still having a few memory issues, some processing issues, just, he had brain surgery and now he's doing chemotherapy. And so there were things that I wouldn't have thought to advocate for. I was so appreciative. His school and the 504 planning team had been very open to whatever, they were incredibly open to any suggestions that John had, that I had, and they said, we can always adjust, which we probably will now that the school year is partially in.
Okay, so just thinking about the different things that you heard today, the different people that you heard speak today, we had some great speakers and some great information. Just think about what you would do. I'm technologically challenged, so I can't see what's going on in chat. But if you'd like to throw some ideas on maybe some accommodations that you would recommend to a school, just feel free to throw them in there. So I met with mom the summer, like in July of this past summer, and we talked about having a meeting with the school prior to school starting. We knew that he coming off of this treatment, coming off of his surgery and the brain tumor, that he was going to have some issues and some concerns. And the school was very willing. They seemed to work with us. So we did meet with the school. We came up with a plan. They did find him eligible for a 504 plan. I explained to the school at the meeting about Jericho's tumor, the treatments that he had. We talked about late effects and how they can affect a child socially, emotionally, and cognitively. And although we were unsure exactly how he would react and do in school, we did know some things, so we were able to get started. We knew that he was going to have difficulty with his memory because that was something that was already being shown. We knew that he was going to be missing some time. We knew his stamina wasn't going to be as high as other students. We knew that we needed to be careful with his port. We knew that he was going to be probably more susceptible to viruses and such, and due to his immune system just being rebuilding. And we knew probably that he would be exhausted by the end of the day, and so we needed to be aware of not giving him too much work to do when he got home. So these are the accommodations that we originally came up with as a team. Allowed to eat snacks and drink water throughout the day just to keep his stamina up. Allowed to take a nap or rest in a quiet area, a classroom, or in another location. Again, in case he got too tired and just needed a break, just need to kind of reset everything. Reduce the number of problems that he had to work on and the quantity of his work, so we could just focus on the quality and make sure we had understanding of every concept. Provide a prompt to wash hands and use hand sanitizer prior to eating, which probably is good for all fourth graders. Avoid activities that could impact the upper right chest area due to his port, and allow for alternative physical activities when appropriate. And extended time up to 1 day to complete graded assignments, not to hold Jericho accountable for any timed tests. And then also preferential treatment, seating close to the teacher. After a few months of school, still got to see Jericho, once a month at clinic, and just talking with mom. There were some concerns that were starting to pop up. She started to notice some different things. But again, I'm going to let her explain exactly the things that she started noticing.
There were some areas of Jericho's academics that he was doing really well on, and some areas that he was doing really poorly on. So, for example, when there were things like social studies and some science things where it required memorization, even though he and I would go through all of his study guides and study every night, he would still get an F on a test, and we were just couldn't figure it out. And so one of the solutions that his teacher has suggested in his parent-teacher conference, which I was really appreciative that John also attended with us, was that she could maybe sit with him and read the test to him, even though his reading level is very high. It appears that sometimes he'll read a question and he won't quite process exactly what it's asking. And so when you sit down and really talk with him through the question, he was able to remember a lot more. So his grades really improved once his teacher started doing his tests with him and just, sort of talking him through, not giving him the answers, but, asking him the question and having him talk through what he remembered studying. And then he was able to really remember a lot of the information that we had gone through and we had discussed. So that was a really big help. I have been really appreciative that his teacher was open to accommodating some of these things, even though I know with the 504, she's not getting any extra help. She's just, accommodating that. But that is something that we will probably be adding into the 504, as well as, just a couple of little things. But it's been really, really helpful being mindful of the fact that, he seems to be, you know, doing so much better now that he's been diagnosed and he's in treatment than he was a year ago, where he was failure to thrive and couldn't even do a whole day at school because he would be so tired and so exhausted and falling asleep at his desk and not able to go out to recess because he would just be pale and tired. And now we're like, oh, he's got so much more energy. But there are all of these little things that we just wouldn't think about unless we had advocated for, hey, he's gone through a lot this year. So, I'm really appreciative of all of the efforts of the team.
So as Mom stated, I joined them for the
There are some areas of
sorry. As Mom stated, I joined them for the parent-teacher conference per her request. And after discussing with the teacher some of the concerns that Mom had about his remembering and recalling the information for the tests and quizzes, we asked the teacher kind of informally if she could read those questions to him, just to kind of see if it would change the outcome and see if he would remember more. She was more than willing to do what she could to help him. I also had Jericho come in and did some educational testing on him and found a couple things. This slide shows some of the things that we found through the educational testing, that his short-term memory difficulties. He definitely had some slower processing speed, significant delay in his writing fluency. His reading, though, was well within the average range. So we connected with the school and decided that we would try to tweak the 504 plan. We asked for another meeting and went into the meeting really thinking that, hey, we're going to ask for a read to see if a teacher or an adult could read Jericho the questions and kind of help him process through the questions so he could answer them. And after talking with the teacher and with the other members of the team there, the teacher said that she noticed that when Jericho actually read the questions to himself, that he was able to kind of figure out the answer and remember the information much better. So that seemed to be a much better option for him if it was working. So we, instead of putting a read to, we just put in there something so he could read the questions out loud to himself, which again is much more independent. He's not relying on somebody else to do something for him, and it just seemed like a much better way to handle things, and it was working. That's something kind of that the teacher added to the team, and into this plan. Not just knowing also that he had the significant delay in the writing fluency. I did ask the teacher about his writing. She said that she noticed that the more he wrote, the longer, if he wrote more than just a couple sentences, that she kind of saw a gradual decline in how well the sentences were written. Tend to get a little confused after a couple sentences, kind of veer off topic. The sentences would have more errors the farther along he went. So we also added in there as well, we talked about adding a speech-to-text software for writing assignments longer than a paragraph. And lastly, we put one-to-one for all state and district assessments, just to allow him to read those things out loud to himself, so he could really get a good idea of what he knows. So, but the thing I really want to focus on, this was such a great experience, and the fact that the school was wonderful, as most schools are, and willing to help, but just the collaboration that we had, and I think that's kind of the best model to use. And this case really shows it. It's Mom, the school team, and myself. I think we all kind of added to the plan, and the working together we were able to really come up with, I think, a plan that's really going to help Jericho and has been helping him to kind of show his true knowledge and be able to demonstrate that. So, just having the parents involved, because they see their child when they come home. They see if they're exhausted. They see if they're struggling with homework. They see if they're working hours trying to get homework done when it should just take a little while. Teachers see what's going on at school. We may talk to the child. I may ask a child and a parent, how are things going, and they don't see anything at home, but then at school you start to notice those things. And thinking back to kind of what some of the young adults were talking about, some of these things were happening. So mom, the parents, teachers, giving their input. Hopefully I can give a little bit of input that can help just add light on what some of these late effects are and some things to look for, and talk about some strategies that have helped in the past with other young people that I've worked with. And when the students are old enough and can express those things, I'm constantly asking them, what's working, what's not working. Do you notice this? Do you notice that? Things like that, just to kind of get their input, because they're really the ones that can give us the best information on how they learn. I think one of the young adults, I think it was Aaron, said that he kind of learned ways to overcome his new learning style. And we want as a team, as a school team, to help these young people figure out how to do that. So I was just so impressed with the school, the parents here. Jericho's wonderful. If you ever get a chance to meet him, he's just a great kid, and he works hard, which always makes things easier on us as well. But just that idea of and the feeling of just collaborating together and working together to come up with these plans, I think is just such a key part to making things successful. So I appreciate your time. I told you I wouldn't take this too long. I do have a little bit of time for questions. If there are any questions, you can put them in chat, and then I guess Susan can let me know if there are any, because I can't see them.
We have one that just came in. Is it not possible to establish a school for them to attend at their pace after recovery to avoid pressure to meet up with lost classes or courses? So I'm wondering if this question is like an independent school, like a separate school, though childhood cancer is actually fairly rare. So it is unlikely that there are enough children in any given location, except maybe really big cities.
And if I could also add that I'm a big proponent of socialization and that social piece being so important. And our child life specialist talked about play, but just the social piece is so important in a child's development and a child's overall education, that I think being with their peers is the best solution for things.
That's an excellent point. Any other questions for John? Give it just a second. It doesn't look like there are any other questions. So thank you, John. We really appreciate it. Thanks for sharing Jericho's story.
Okay.
All right. Our second case study is an example of a student in survivorship presented by Lisa Mears, Ask Education Support Navigator at Inova Char Cancer Institute. Lisa has 5 years of experience as a special education teacher and 4 years as a social emotional special education teacher. In addition, she recently completed her master's in human development. Welcome, Lisa.
Hello, thank you for having me, and thank you everyone for being here and sticking it out through a long day and taking the time to listen to our survivor stories and learn a little bit more about the educational impacts during and after treatment. I want to talk to you today about another case study. This one is rather than a specific patient or student, this is a culmination of patients and students that I've worked with is my time as an education navigator. So as you're learning about this, know that this is not just one specific patient that I've worked with, but rather a culmination, but very real experiences that have occurred nonetheless. And I do have the chat up on the side, so I'm going to do my best. As a former educator myself, I love to have the participation. So if you are willing and comfortable at the end of this long day on a Friday to put your input into the chat, I would love to have it. And I'm going to start with taking a look at what you as educators would see this child as first. So I'm going to move ahead. Slides will cooperate. There we go. So as an educator, as a school staff member, what you know is this is an 11th grade student. They came to the United States at the age of 10. They were 4th grade at the time. They were non-native English speakers, so they took the appropriate English language learning courses and supports. Now, at the age of 17, they're in 11th grade. They have passed their required SOL testing. If you look closely, they've just kind of skirted by, like they're making the bare minimum, but they have passed. When they're engaging with others, whether it's staff or students, they are respectful. When it comes to the academic end of things, they are often not turning in assignments on time, if at all. They're consistently late to school and or classes. It could be missing up to half a day or more. When they're in school, they are spending a lot of time out of class. Maybe they're leaving for the bathroom and not coming back in a timely manner, or coming in late. So looking at what you as the staff would know, or as an educator would know about this student, is there anything that you might do to support them, just having this information? And if you have anything to share, I'd love to see it in the chat. Give it a moment to see if it pops. Not seeing anything just yet. That's okay. Oh, do they need supports to complete assignments? Yeah, so you might be thinking they're not turning it in, so what kind of support might they benefit from, or could they benefit from if they're needing help turning in assignments? That's excellent. So now another end of it would be the medical side of things, because we know that this isn't just a student. This is also someone who's survived cancer. So this is, in this case, this patient is a acute lymphoblastic leukemia survivor. So from the medical end of things, what the medical team knows is this is a patient who is, again, 17 years old, was diagnosed with acute lymphoblastic leukemia, or ALL, at the age of 12. So we're kind of combining that timeline. They would have been in about 6th grade when they were diagnosed. So they did have some time to be in person learning both the language, the culture, and the academics prior to diagnosis. They were a non-native speaker. Now they're fluent in English. However, their parents remain not fluent English speakers, or very limited English proficiency. The medical team is aware that they've completed multiple rounds of high-dose chemotherapy treatment. They have remained in remission, and they do a great job of attending their fellow appointments and the survivorship clinic annually. At their most recent clinic visit, they come in and express difficulties as it relates to the academics, which staff have probably already been seeing, which kind of triggers in their mind that this might be a good time to review and consider and explore the potential late effects from treatment. Now, of course, we're looking at this and we have the school team's perspective and what the medical team's perspective is. But we're talking about an individual here who has their own perceptions and also their family's perceptions as well. So as I look at the next slides here in just a moment, I want you to think about the information here, and then also the information, the perspective that the student has and the parents have about the school, their child's academics and their own academics, and how that might shift what you're thinking, what supports might be beneficial, if any, and feel free again, throw them in the chat. I'd love to see what you're thinking as we progress. I do see some people saying them giving some safe spaces just based off of this right now. Maybe some working at their own pace, electronic submissions, maybe reducing some workloads. You guys have some really great ideas already without even getting their student perspective or parent perspective. But let's take a look at those briefly. So from this child, young adult, really at 17, their perceptions, they know that they had to move to a whole new country where they had to learn a new language and a new culture. And they're consistently going between the two at school and at home. They had this experience with cancer and going through chemotherapy treatment, which meant that they missed a lot of opportunities for in-school learning. And a big part of that also is the opportunity to engage with peers. If we're getting into the nitty-gritty of it, and they're currently 11th grade right now, we think about they were in 4th grade when they moved here, 6th grade when they were diagnosed. If they were going through treatment, into 7th grade, around 8th grade, what would have happened at that point when they're trying to transition back is we had the COVID-19 pandemic. So their opportunity to re-engage in the classroom learning and get reconnected with peers that maybe they were disconnected from for a period of time was kind of missed because we all had to go virtual. So that's something else to add, just another layer to what this child has experienced. And then they also, of course, they know that they have a hard time focusing in class and they often forget information. They're not really sure why that's happening, but just that that's something that is difficult for them. On the other side, we have what the parent knows and thinks. They know that their child had cancer and respective treatment, that they don't speak the same school language. So they have to either work harder to find out what's happening in the school than the average English speaker, or they're relying on what their students telling them. And they know that historically pre-diagnosis, pre-COVID, pre-treatment, everything, that they were a good student, but now they see that their student doesn't really care. They kind of have this perception, well, my child's just really lazy. I tell them, go to school, do your work. I tell them, when you go home, you have to do your homework. But, at the end of the day, we all know parents also have a heavy load to bear as well. And so that they don't always have the time to monitor. And we also expect at 17 years old that a typical 17-year-old hopefully has some independence, or you would have that expectation of more independence, barring these sorts of experiences. But they do recognize that their child is still quite capable, and they're going out constantly, and they're just wanting to engage in local soccer games and just practice playing soccer in the yard. So knowing all this information of what the school knows, what the medical team knows, the child knows, the parent knows. I see some things popping up in the chat of what you might think now would be beneficial to this student to be successful in school. And I know someone said, having a 504 team, that's absolutely a great idea, is gathering the 504 team to talk about this, getting the perspective as a whole, which is really kind of my goal here, is that there's many different moving parts, and often we don't see all of those parts at once. So having that team come together to talk about all of the experiences are really important. Yes, an interpreter for the parent. Thank you. get them caught up, make sure they're understanding, take that time to get those documents translated so that they have a better understanding of what's happening and they don't have to rely on their child to be telling them what's happening in school. Someone suggested getting some neuropsychological testing to target some academic difficulties, looking for appropriate accommodations. And oh, I like this one. There's a lot of schools are saying offer some alternative classes for those that work at their own pace. It could be a good one, but I would caution with that one, depending on the conversation of what benefits the child. I think John mentioned, checking in with the student of what works for them, because if they're learning at their own pace, they might need someone who's kind of there helping guide them, and having them move at their own pace might be something they're not moving at their own pace now, working independently, so the own pace might not work for them. Or convert on the opposite side, it could, if it's the pressure of I have these so many deadlines, working at their own pace may be a source of anxiety relief, so to speak. Add an accommodation where there's a live working document with an up-to-date to-do list. Lean into the technology tools for translation information for parents, help guide students. Sounds like you guys have a lot of really great tools that you have to either you knew previously or from today that would be good to support the student as a whole and this family as a whole. Because I'll tell you, this is when I had this experience, it was a very moving experience, because when I went back in the medical team, it was a survivorship clinic day, and the provider pulled me into the room and said, they just don't know why they're not focusing, and they're not going to school half the time. And I walked in the room and, I said, you were younger when this happened, but has anyone ever talked to you about late effects of treatment? And I imagine that the providers have talked about it, may have even reviewed it within that appointment, as they often do. But just taking the time to sit there and reiterate that there's maybe a direct connection to the treatment that you went through and your lack of ability to focus in class, and retain that information. And quite honestly, if I could have taken a picture of the face of the dropped shoulders, the relief of, this isn't like, there's nothing wrong with me. This is just a part of my journey and what's happened to me. And this is normal given the circumstances of the experiences that I've had. And they quite honestly were saying they were skipping out on those classes because they couldn't they couldn't focus, they couldn't retain the information. And then pulling the parents into that conversation, on the same spectrum too, they were, rightfully so, more focused during treatment of, I need to help my child survive this, get through this, my family to survive this, to get through this, that their focus wasn't thinking about the late effects. And I'll tell you that they cried when they heard it, and they said, all this time I thought my child was just lazy and didn't care. And I just had no idea that they were struggling with such things. So to kind of sum up what I'm hearing and seeing a lot in the chat is, and you guys gave a lot more accommodations than I listed even here, is looking at, extra time to process information. You might be modifying that workload. How that looks may be different depending on the student. Some of that self-paced or the technology pieces that you guys were talking about in the chat are definitely great ways to do that. It could also be looking at quality over quantity of work so that they have less of a workload, they don't feel overwhelmed. Again, it's really based on having that conversation with the individual, especially at 17. We do want them to be working towards independence, but we want to support them towards that independence. Giving hard copies of notes, checking for understanding, or even checking in, having an adult in the building to kind of check in and see where things are at. And as some of you mentioned, the 504s would be those accommodations, but you may actually go on and say, you know, let's push ahead with evaluating for possible impacts of the late effects, especially in the area of executive functioning, since he's, you know, the student's talking a lot about having difficulties with the way they process and hold information. So you might look at doing a full cognitive evaluation and educational assessment and bringing it back to the school team to talk about what the findings are and if they qualify for an individualized education plan, what goals and services might they benefit from in addition to many of the accommodations. And then as several people mentioned in the chat, that you're ensuring there's, you know, interpreters, hopefully able to get any documentation translated into the native language of the family to provide that inclusive, supportive educational environment that I know so many educators work so hard to do every day as we live in such a diverse community. I'm going to see, I see we have a little bit of time. And I think I see a couple of questions. Someone asked the question about, is it advisable to allow them to go into soccer? In this situation, I would say, yeah, they're long out of treatment. They don't have any late effects that would limit mobility or cause any sort of pain. Again, I'm not a medical provider, but as long as they feel able to do it, it might be a sense of support. And actually, I might even see if maybe that's a way to hook them into school and get them connected if there's like a school soccer team or a school soccer club. That maybe if they're able to get some more buy-in to school with appropriate supports and everything, that it might be a motivational thing to get that pulled in if we know that that's a high interest area. Let's see, what other questions? So someone asked, how many survivors do you see at Survivor Clinic? So I am up at a Nova Shar in Fairfax, and I don't know honestly the exact number of patients that are seen annually, but I want to say it's over 100. I right now, as it's only my second year in this position, so we are still growing and learning about how to best serve our population. The goal is eventually that I will be able to touch and support each one of those survivors. But I've obviously not met that goal just yet, as I'm still growing and learning in this position. A lot of mine has been more focused on a lot of active treatment to support those kiddos that need the homebound services and 504s as they're returning back to school, doing school lessons. But there are quite a lot of survivors out there. We have survivor clinics 2-3 days a month. And they are fully booked days with, I want to say like 15 patients a day. Math is not my strong suit, but if someone wants to take the time to tally that up, that would probably give you a good estimate of, at least in the area where I'm at, the amount of survivors that we have. Checking the chat to see if there's any other questions. Susan, if you see any that I missed too, feel free to let me know.
I think you got them all.
Excellent. Well, again, thank you all so much. And I appreciate your time and your efforts to learn more about these experiences.
Thank you so much, Lisa. I think these case studies are so important just to get a real life example of what's happening. And I love the comment, education about late effects. You just answered all my questions and now all of the teams can work together. That's our goal. So I love to hear that. We are going to have a final Q&A. I think we may need to take a quick break just to get Alma Morgan on. She is going to do our final, answer our questions in our final Q&A. Ishan referred to her several times. She's a beloved member of the ASK team. So I think, see here. We are going to go to break. Why don't you go ahead and start typing your questions into the chat, and when we get back, and it'll just be a minute, and then we'll answer questions. All right, we're back for our final Q&A. So if you have any questions, if you can type them in the chat. I did want to follow up on the question about how many survivors are seen in survivorship clinic with Alma. So Alma works in the SHORE survivorship clinic. So that's Children's Hospital of Richmond at VCU. I apologize for the acronym that everyone would not be familiar with. And it really varies the size of the survivorship clinics based on the treatment centers and the size of the treatment centers and how many patients they see. So Alma, I know you can speak in detail about Children's Hospital of Richmond Survivorship Clinic.
Yes, we meet every Monday. Some of our clinics, well, not at VCU, but across the state, some of the treatment centers, they might meet only once a month. But at Children's Hospital of Richmond, we meet every Monday, starting at 8:30 and going to about 4:30. I think this coming Monday, we're going to have about 19 survivors come in that day. So the numbers vary. Some of our survivors, when they first start coming to us, they might come once a month, then it goes to 3 months, 6 months, and then once a year. And I think last year we had close to 600 survivorship appointments. Of course, some of those were, repeat survivors coming twice a year. So, but I think probably active, we probably have about 350, 400 survivors in our program.
And how, so it's a pediatric survivorship program. So when are they, and this may vary by treatment center, but when do they move out of pediatric follow-up?
That is different for each treatment center. I know some treatment centers might see their young adult might end at 24, and then they're referred out of the survivorship clinic to the primary care providers. At Children's Hospital of Richmond, we keep them forever. So I think I have some young people that are in their late 40s, early 50s that we are seeing. And it's a reason for that too, because I know our young adult survivors, they tell us all the time, because we do have a really large young adult cancer survivor group that gets together, and they say, we're tired of telling our story to new people, providers, and us, and where we've been and where we're going, and said it's always so hard to start over. So we just keep them forever. But that is not true of every treatment center.
Right. We have a couple questions came in the chat. Are the camps for survivors /siblings /patients helpful?
Absolutely. You can learn so much at a summer camp. We have lots of fun. I have to admit that we have lots of fun, but you learn so much about their socialization. You learn so much about their educational needs. And at the same time, I love our morning discussion. And I've had some kids tell me they like that. At morning discussion, we spend 30 to 45 minutes getting to know each other, talking, getting to know sometimes before summer camp when children first start coming, they're not really sure of what type of cancer they have. So we talk about the different types of cancers. They go home, they talk to their parents. They learn that I had leukemia or I had Wilms tumor, their age, and they learn how to start telling their story. And then we talk about our strengths, what are we strong at, and then we talk about our challenges. We talk about problems we might have at school, how to advocate for those problems, and how to be, a good friend to others. And if you feel like you're being bullied, where to go for help and support. So we cover all the bases, I think.
So Ask provides it's a day camp, 1 week of day camp in Fredericksburg, and then 4 weeks this summer here at our Family Center office in Richmond. There are some other organizations that do summer camps for patients, survivors, and siblings. In Virginia, there's Special Love that does some camps. And I think just that socialization piece, and as Alma was talking about, having interaction and getting to know and build community with other kids who understand what they've been through and what it's like is so impactful. Another question that came in, is there a volunteer program at the Children's Hospital of Richmond currently?
Yes, yes, I know that was stopped during COVID, but I think they've started up, and you have to go through the hospital and go through volunteer services. And there are always opportunities for volunteer opportunities at Ask.
That's right. Good plug, Alma. I was remiss in not introducing Alma. I got distracted with the technology and getting questions started. So I am going to introduce you, Alma. Alma is our Associate Director of Education here at Ask. She has provided educational support to childhood cancer patients and survivors for over 30 years. Through her advocacy work with the Virginia General Assembly, Alma played a key role in securing funding for educational support of childhood cancer patients, survivors, and their families. Starting in 2022, Alma helped create, launch, and manage the Ask Education Navigator Support Program at the 5 primary pediatric cancer treatment centers in Virginia, ensuring all children in Virginia diagnosed with cancer receive equitable educational support for the first time.
Thank you, Susan.
Very lucky to have Alma. Let's see if we have any last questions that have come in. I wish I had known about Ask when my son was diagnosed with a brain tumor. Definitely share with other families. So we here in Richmond, for families and patients treated at Children's Hospital of Richmond, we usually get connected pretty quickly through the outpatient clinic. Sometimes I think when kids are diagnosed and then inpatient for a long time and they don't make it to outpatient, it's a little harder to connect early on with some of those families. And then in the other 4 treatment centers in the state, we reach families through those education support navigators. So when they come to clinic visits, that's when they introduce themselves. And so yes, it is our goal to connect with families as quickly as possible to be able to start providing services. All right, it doesn't look like we have any other questions in the chat. Thank you so much for joining us today and for your partnership and commitment to supporting the unique challenges of childhood cancer patients and survivors. Thank you to our presenters for sharing their time and expertise with us. We hope that you come away with a greater understanding of the childhood cancer experience and the important role school personnel have in helping to ensure patients, survivors, and siblings receive important educational support. Please remember to complete both the pre- and post-conference surveys to receive your CEU or CNE certificate. We will accept post-survey responses until February 29th, and then we will begin emailing certificates March 4th. The Ask Childhood Cancer Foundation can continue to be a resource for you and your school. If you are supporting a child treated at one of Virginia's 5 primary pediatric cancer treatment centers, there is an Ask Education Support Navigator available to help support your school-based team as you work with a patient or survivor. Please take advantage of the Ask Childhood Cancer Education Toolkit that you can find on our website, and I believe link will be put in the chat again. Please don't hesitate to reach out as specific questions may arise as you implement the knowledge and tools that you learned today. Thank you for being a champion for kids with cancer in your school. Together, we are making life better for kids with cancer.